Thank you, Joan. I thank you everyone for being here. We are ready to start today's meeting of the Committee for Resilient Nevada. I'd like to call this meeting to order and begin taking roll call of the members. Joan?
Jessica Barlow.
Present. Good morning, everyone.
Brittany Collins Jefferson.
Good morning, present.
Lenitra Grady.
Good morning, I'm present.
Dr. Kamyar.
Present.
Ryan Gustafson.
Present.
Karissa Loper.
Present.
Catherine Loudon.
Good morning, I'm here.
Cecilia Maria. Elise Monroy.
Present.
Present.
Okay, and I see that Cecilia Maria just joined. Darcy Patterson.
Present.
Pauline Sala.
Present.
David Sanchez.
Present.
Ariana Saunders indicated that she's in a different meeting right now and will be coming in when she can. Cornelius Sheehan.
Present.
Laura Sherwood.
Present.
And Dr. Wagner indicated she would not be attending today's meeting. And Quinny Winbush.
Present.
You have quorum.
Thank you, Joan. We will now move to agenda item number 2, public comment number 1. Again, public comment will be taken during this time. In consideration of those others who may wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. Do we have anybody available or interested in public comment? I have Katri's hand up, Joan. Katri?
Hello, can you guys hear me?
Yes, ma'am.
Perfect. Grand Rising. I just wanted to make sure that my recommendations were reviewed.
Yes, they have been, we have received them and they have been entered into our report that will be going to the director's office. They're listed underneath the public comment section of the ACRN report.
Okay, great. I'll be here listening and I'll give any input if I have any further recommendations. I appreciate you guys' time today. Thank you.
Thank you, Katri. And again, we added the link that you submitted to us to the report that's going to the director's office, and that's under the public comment section. Thank you for being here today.
Thank you, appreciate it.
Yes, ma'am. Do we have anybody else that is on the meeting that would be interested in providing public comment at this time? If you use the Zoom tool to put your hand up, I can call on you. If not, we are going to move forward to the next agenda item. At this time, I see no one else interested in making public comment for this agenda item. And I will be moving on to agenda item number 3. Agenda item number 3 is for possible action, and it's the approval of the minutes from our June 15th meeting. And actually, we are going to table this item to the next meeting. We have a lot to do today, and we will have the minutes provided to the website and to the committee, and we will go over them at our next meeting. Before we move forward to agenda item number 4, I'd just like to ask the committee that if possible and your committee member. Oh,
sorry, this is Henna Rasul, Senior Deputy Attorney General. The open meeting law, it's
it basically requires that you approve the minutes at your next public meeting. If not having a public meeting, then as soon as you can. So I would recommend that you just go ahead and quickly do that.
Thank you, Mr. Sewell. Joan, did we get the minutes from our last meeting posted to the webpage?
I have not been able to complete them. Have not been able to transcribe them yet.
Okay.
That's fine. If they haven't been completed or you haven't done them yet, that's fine. Okay.
Thank you, Mr. Sewell. Thank you, Joan, for clarification. We will move to agenda item number 4 at this time. Again, I'd like to ask the committee, if you are a committee member and there's nothing stopping you from having your camera on, we appreciate your cameras on so that we can see you here and see you present. Again, if any committee members which wish to speak on as we move through our recommendations, if you have a comment or a question or need clarification, please use the Zoom tools to raise your hand. I will call on the people that have raised their hand in order as best that I can. And after you have been addressed, if you could then press the raise your hand button again so that I can close, or so that I can see that you no longer have your hand up, I would appreciate that. Right now I have Brittany with her hand up. Brittany?
Good morning, Mr. Chair. I will be on camera. I'm still doing my morning drop-offs for my children, and once I get in the office, I'll be back on camera.
Great, thank you so much. I appreciate that. It's kind of difficult to tell who has their camera on and who has their camera off as we look at the Zoom. But again, I just wanted to put a reminder out there. If any committee member is able to, it would be best if you had your camera on. If you need to step away, that's totally understandable if you're doing something. But if you can have your camera on, we would appreciate it. Moving forward. Oh, and then there was the bit about the hand raising. If you can raise your hand so I can call on you, and then again click the button so that it goes down, so that I know that you're no longer interested in speaking. If I see it up and not go back down, I'll just double check with you so I don't skip you. So moving to agenda item number 4, we have for possible action, discussion, and possible approval of the prioritized recommendations concerning the allocation and distribution of money from the Fund for Resilient Nevada. Just like to say that we know all of these recommendations are important. That is why they are all going to the director's office. We need to let the director's office know what we want highlighted. Any recommendations that have been rated cannot be edited, as that would change their ratings. We are moving forward our recommendations for funding priorities for the abatement of the harms, risks, and impacts of the opioid epidemic based on the principles for the use of funds from the opioid litigation established by Johns Hopkins. These principles should guide prioritization to spend money to save lives, use evidence to guide spending, invest in youth prevention, focus on racial equity, and develop a fair and transparent process for deciding when to spend the funding. So we will continue where we left off last time, which is everybody should have a copy of the Excel sheet or the PDF, and Dawn will be sharing her screen as we move forward. We are still working through the bottom half of the legislative category, develop workforce. And at this time, we will consider the last 4 for develop workforce, which is recommendation number 92, 95, 113, and 163. Does anybody on the committee feel that any of these 4 recommendations need to be pushed forward as a priority from this committee? And I have Pauline with her hand up. Pauline.
Let me lower my hand right now so I don't forget. I like, well, I had 113, and I just needed more information about 163. Like, is that through the universities, or how would that work?
That's a good question. I believe that one came from one of the state agencies or maybe Dr. Woodard. Does anybody have any comment on maybe help with clarification for Pauline for number 163? I don't see any hands up.
Then Chairman Sanchez, I had 113 to move forward.
You had 113?
Yes.
I had 113 also. And number 95, Dr. Kendra?
Yeah, Farzad here. So 95 is one that I recommended. And this was simply because I didn't see anything in regards to one of the John Hopkins principles, which was basically this, right? And so I was imagining, oftentimes with things like this, we have the public, and the public is like, there's hundreds of millions of dollars coming in. What's going on? So that was sort of the basis behind that. Here's the number, call, ask your question. How much went to this organization? How much went to that organization? What's it slated for? What's going on? Just to sort of be in line with that tenet of being inclusive, transparent, accountable, and responsible to the citizens.
Yes, absolutely. Thank you, Dr. Kemner. And I agree with you. I also have number 95 highlighted, and I just wonder what that will look like in practical application. Paulina, have your hand up?
Thank you. One of the reasons I didn't have 95 is because the funding is coming through state agencies, and that should already be occurring. We should be transparent. We should be accountable. People should be able to call and ask questions. So I felt like it was duplicative of, it's public information what the funding goes to already. And I just felt like that would be taken care of. So if that's not correct, then I can revisit that.
No, I totally see where you're coming from. And I believe it may be in a sense, but at the same time, if we include it in our recommendations, I think it further ties it to the response to the opioid epidemic. So I think that my inclination is to leave it in there so that if it does exist, that it somehow is also tied to the remediation of the harm from the opioid epidemic. Any other thoughts on 95 or any other comments on these 4 items?
Chairman Sanchez,
Yeah, please.
I guess the establish an office is what gets me, because we should already be doing that as a public agency. And so if it's between establishing a new office to do this and take away funding from direct services, that's where I would get concerned. So the established piece is what I'm concerned about. To me, that's a
Yes.
new office with additional funding, new staff, and all that stuff.
I totally see what you're saying, Pauline. Elise?
Thanks, Chair. This is Elise Monroy for the record. So I just wanted to confirm we didn't get an answer on 163. And it also sounds like that recommendation didn't come from somebody on the committee, but state staff.
Mm-hmm.
So I just want to confirm that we're considering recommendations that came from this committee as well as state staff. So these aren't just our committee's recommendations, but the state's recommendations as well.
Yes, that's correct. And then our job is to sort through them and determine which ones are important or priority for us to list in our report to the director's office, so that they have a sense of what this committee and its the expertise that this committee brings is established as important.
Okay, so then I would just say if we can't get clarification on establishing addiction medicine fellowships from anybody, like there was no one on state staff to provide clarification, I say that one is deprioritized. And I just also, while I have my mute off, want to second Pauline's comments about transparency. Transparency to the public of public agencies should just be baked into the process that the state is using to administer these funds. So I agree with Pauline.
Thank you, Elise. I think I have Jessica Barlow. Jessica.
I was just gonna say that I also agree with Pauline as well. On I think it was item number 95. Let me see here. Is that the one that was being discussed about establishing a transparency?
Okay.
Yeah, so number 95. I think what bothers me about that also is establishing an office of public engagement. I think the rest of it, transparency, accountability, responsibility, all of that, I think that's great, but establishing an office, when I read that too, same thing, I just thought that would draw away funds that could be used to make a bigger impact.
Great, cool. Thank you so much, Jessica. The number 95 is already established, and actually Joan and Donna are part of that team that aims to engage with the public, being transparent, accountable, and responsible for Nevada residents. So I think that with the discussion we've had on 95, we will not highlight it as a priority of this committee, and we can feel comfortable with that because it already exists right now. So there's no need to duplicate it and add it and move it forward.
That doesn't match. Find different shorts.
I'm sorry. Can you say that one more time? Oh, got you. So that being said, I have hands down. I think we're going to move forward and move on to the next category, which will move 113 forward, 92, 95, and 163. If you could hide those for us, Dawn, I would appreciate it. It looks like I have an attendee with a hand up. Katri has her hand up. Katri, I'd just like to let you and the public know that we will be taking a second agenda item for public comment number 2. You can make some notes about what it is that you'd like to comment. I will be calling for public comment number 2. As we move forward, I would like to start with recommendation below 113 that has not been put through the objective tool, but it is still something that we have an opportunity to move forward if it is important to this committee. And we will kind of slide into the legislative category, education awareness and awareness campaign. Sorry about that. And we will work on the one right below 113 all the way down to number 31. So do we have any comments or questions about these recommendations, and does the committee see any that they would like to move forward as prioritization? I'll just say that I have 14, 24, and 27 highlighted on my list. Pauline?
If I remember correctly, and maybe it's because I just read this so many times, so I might be confused. But didn't we already talk about awareness campaigns?
Pauline, I'm sorry to interrupt you. I just wanted to point out that your audio is cutting in and out. It's between low, unhearable, and reasonable, almost every other word or every third word. So I don't know if there's anything.
I may need to call in. I think my camera might be having issues. I'll call in on the number.
Okay, thank you so much. I'll be sure to call you when I see you enter back in on the from the call in, because it's really, really difficult to catch your words. Karissa?
I just wanted to clarify on my new recommendation. It was more that I was going through that process in my head of rewording them, which I didn't realize I didn't need to do. But it was more that I had separated that from, I think 14, because I was trying to make things more specific. So I don't think it's a new recommendation truly. I think it's tied up in something we may already be sending forward.
Yes, and I think that makes a lot of sense. And I think it was a little bit confusing as far as what our availability for wordsmithing is, but if we, consider it as part of or included with number 14, I think that we can highlight number 14 at this time to consider for moving forward. Pauline, I would like to have your participation because you've had some good things to say, and I want to hear your point of view. Did we get the audio situation adjusted at all?
Sorry, it's asking me for a panelist ID, and that's not on my email on the phone call. If Joan could send that to me, that would be wonderful.
Joan, is there a way that you can send that to Pauline so she can call in? She's having difficulty with audio, and if we could get her on a call, but she doesn't have a panelist ID. Pauline, while Joan works on that, I'll be looking for a message from her to confirm that she sent it over to you. But while she works on that, I'd like to ask the committee if we have any comments or questions for number 14, 24, 27, 31, and 32. Catherine?
Yes, thank you. I think all of these are so important, and I can see an interrelationship between so many. But I think expanding some educational efforts in schools to produce early intervention and reduce stigma is important. And that interrelationship and connection between mental health, stigma, suicide, substance misuse. I think that one is an important one to bring forward as well.
Thank you, Catherine. And just for confirmation, Pauline, you should have or be receiving an invitation from Joan with an ID number. I have Darcy.
I agree on putting 32 forward.
Thank you, Darcy. Cornelius.
Thanks, Mr. Chair. But for some of the reasons cited, 14 through 32, I'm also in agreement with moving those forward.
Thank you, Cornelius. Dr. Kamiar?
Yeah, Farzad here. I absolutely in agreement. However, I think that it would be important to specify what populations we're talking about. For example, I basically mean that this should be public educational campaigns for all of this stuff, in addition to, if it's not called out elsewhere, for clinicians, medical professionals as well.
I noticed that too. Absolutely. I think that that's just as important, equally as important as what the essence of these recommendations 14 through 32 don't have included, but it would be absolutely like a must. So I think with that, we will leave 14 through 32 highlighted as green to be included in our report to the director's office. I have Cornelius with his hand up. Catherine, do you still have your hand up? Or thank you, Cornelius.
Thanks, Mr. Chair. I believe with regard to what Dr. Farzad was saying, or Dr. Kamiar, pardon me, there was another item somewhere, one of the recommendations that did wrap in public awareness and education, or I'm sorry, professional awareness and education, I believe. Do you recall that at all, Dr. Kamiar? There might have been another one about educating physicians, pharmacists.
Yeah, there could be. So I guess just consolidation, right? If we come across that at some point. And then there might be specifics on differences. For example, I believe in what you're referencing, I have been trying to hone in on stuff regarding clinicians and practitioners in regards to opioid prescribing and all that's kind of involved in there. which would be a little different, right, than some of the specifics that are included in these.
Thank you so much, Dr. Cameron, and thank you for your question and clarification, Cornelius. Elise, you have your hand up?
Hi, yes, thank you. So I know that we can't wordsmith, so I'm not really sure what to do with this comment, but I guess I just want to say, I kind of feel like the state has funded 14 through 32 through various federal grants, and various other grants to, for years. So I guess I don't know how we ensure that these initiatives to do marketing and education are done in a way that is, I don't know, it just, I'm having trouble finding the words, but this kind of feels like we're proposing to prioritize work the state is already doing and has been doing for the better part of a decade. So I'm not sure how to handle that. Thank you.
Yeah, no, that's a great point. Thank you so much, Elise. And my understanding is that the director's office, because of the litigation done to abate the harms and impacts caused and done by the opioid epidemic, is going to receive a mass amount of information from committees like ours and our committee. And the hope is that when we give them a list or a direction of what is important from this committee specifically to address, that these things would be highlighted. If they're not implemented. If they are implemented, looked at again or further supported. But I don't think that the committee has a specific way for this committee to say, you know, what, take 24, for instance. This is kind of already being done, and it has been done for years, as you said. But I think it draws more attention to the matter and draws more attention to the issue, just like 14 through 32 as a whole do. So I think that we're helping the state map out all of the funds coming in from the opioid litigation. And our goal is to make sure that we highlight priorities that will be put into the state plan. So I think that just informing from our point of view of expertise as a committee, the state's or the director's office, that it will have a direct impact on the state plan. Karissa?
Yeah, thank you, Chair. Karissa, for the record. So I hear what you're saying and understand, right, like what's going to the director's office. I am wondering, because I can't remember all 100 things, and I'm trying to pull up my spreadsheet, but is there anything in here about evaluating things that have already been done? So we could always recommend, if it's not in here somewhere, that the state use these funds to evaluate media campaigns, the effectiveness of any various media campaign they already have going on. That would, allow them to understand the successes, the barriers of that particular outreach, implementation and programming, etc. So if that's not already baked in somewhere or isn't its own thing, I would recommend that as a new recommendation, I suppose.
So there are a few of the recommendations throughout the entirety of the 100 and something recommendations that do specifically target evaluation of programming. But
Okay.
they might, so I don't think that we need to go through and say evaluate every single thing, but where it is included, I think that we would want to highlight as something that we find needs to be done for sure. So I believe that we may have done one already out of the portion that we did get done last meeting that said evaluate, but as we move forward, I imagine that we'll find one or two more. And then, yes, I mean, so again, we're steering the dollars by steering the state plan, by pushing over our recommendations that means something to us. I don't know if that's a good enough answer or if I provided clarification on the whole, the last two comments, but I think we're on getting towards the same page, and I think that there's a clear understanding as far as what our role is and what will happen once we get our information to the director's office and how that'll look in the state plan. And again, we will get an opportunity to review the state plan as it's being developed and pushed forward. At this time, we have 14 through 32 highlighted, and I think that we're all in agreement on those four. So let's leave them highlighted and move down the list to the next grouping, which we have. We're still on a education and awareness campaign. We have 34 through 36 in this batch. On my individual page, I have them all highlighted. Oh, I have Pauline. Pauline, your hand is up. There you go.
Can you hear me now?
Yes, 100%.
Okay, I just want to let you know I dialed in, so.
Thank you so
now it
much.
seems to be better. Thank you.
Yes, and I can totally hear you now. Thank you for doing that. Sorry about the technical issues there. Does anybody on this committee have any comment for, oh, I have Catherine.
So I do, thank you, Catherine Loudon, for the record. I do think that when we look at 35, and I know it's not highlighted and maybe it's combined with others, I do want to mention that this is very much an issue with students, even, you know, their perception that they can't bring it up, or that what to do if someone's sleeping and looks not responsive. So I could see that as related to some of the other components. I don't know if that could be put with something very purposefully, but I would like to see that.
So I'm sorry. I was just going to say that it seems like 35 is the only one that I see that isn't already happening. So, but the others, and on my list, I highlighted 33, 34, and 36. So I guess right now we can further hone how we're going to do this. So far, we've been moving with the premise that even though 33, 34, and 36 already exist in some type of way, that we would push it forward so it draws more attention to the issue. But at this time, if we want to focus down a little bit, we do have the opportunity to do that. And in that case, I would suggest that we move 35 forward on its own, because that definitely isn't mixed into anything else and doesn't have any other kind of connection or anything to anything we've seen so far. Quinny?
Yes, Quinny for the record. I just wanted to say that I agree on 35 as well. It's very important. I feel that, you know, the children, middle school and high schoolers, they might have parents that are fighting substance use disorder, and then they'll be able to know what you do to help their parents. You know, they might save their lives. So I'm just in agreement with 35 as well.
So, you know, and I'll call on you next, Cornelius. As I look at these four, I just don't feel that it would be, I at least see number 36 as something we need to move forward. And it probably already exists, but it needs to be done more, and it needs to be highlighted as something important by this committee. But, you know, do we also include 33 and 34 with that? Because those are kind of happening. But Cornelius, you put your hand down.
Oh, you acknowledge me, Mr. Chair, so.
Oh, sorry, go ahead. Sorry,
I'm being careful not to keep the hand raised.
I apologize, that was my bad.
I just wanted to add my voice to 35, you know, as Catherine Loudon or Quinny had suggested. I think 35 is really important. It may wrap in, I recall it wrapping in, I don't have the sheet in front of me, possibly to other items, but I think an emphasis on that is critical. That can be a lifesaver.
Absolutely, thank you.
Thank you.
Pauline?
Thank you. I like 35 too. I guess my concern is that if the education system doesn't support it, then it only goes to certain areas in Nevada. It's like our SOS trainings. Some schools it's mandatory, some it's not. So I support 35. I'm just concerned of how we get it statewide and not just in certain areas.
Okay. Laura? Thank you, Pauline.
Thank you, Chair. I do support 35 as well. And in order to reach the bulk of our students, whether or not that is in concert with our school system, the school districts and private schools, and whether or not that looks like something that's an in-house curriculum or we hire certified prevention specialists, it's of utmost importance.
Thank you, Laura. So again, we are confident in moving 35 forward, but as we look at 33, 34, and 36, these have been added to the recommendations specifically by this committee, either an individual member or something that we have gone over before. But as we look at them, they're kind of redundant, you know, something that is already included, something that's already been done. And as we first get started going over these four, I had mentioned that we have an opportunity to kind of make it further clarified of what is important to this committee, or lump what we, all that we can in, so that it is highlighted as, you know, make sure that it exists, make sure that it's getting some attention. If it exists already, make sure that there's some other type of support being implemented towards it from the litigation funds. That being said, 34 specifically speaks to enhance understanding of recovery targeted at employers and landlords. You know, so the generalized stigma campaign and awareness for awareness has been included. Do we want to include 34, or do we count that as something that's already involved in what we've pushed forward as a recommendation? The same goes for 33, and then I would also like this committee to acknowledge 36 and highlight that as one of our recommendations moving forward. Pauline?
Thank you, Chairman. So that's one of the things I was replying about when I was cutting out. I feel like that the public awareness campaign we've addressed already in another area, but maybe I'm wrong because I've read this so many times. I guess for me, 35 and 36 is what I would move forward, with the preface that 33 and 34 are built in already in other, maybe they're already happening, or other areas.
Yeah, totally. So I don't have any other hands up.
Chair, may I?
Please.
This is just a reminder to everybody. We are currently in the office that we're sitting in right now, the Resilient Nevada unit. We are starting mapping of all of the opioid dollars. So just to keep that in your head, just because you move this recommendation forward doesn't mean it's necessarily going to go into the state plan, because we are doing this mapping to make sure there is no supplanting. So I just wanted to let everybody know that, yes, we can move them forward into your report, but we are very aware of potential supplanting. And so we don't want to move it forward into the state plan if it's already happening.
Which basically, to cover our bases as a committee, I say we move them forward, and then, you know, there's a team working on making sure that we're not duplicating or over committing to one type of issue. So that being said, how does the committee feel about moving 33, 34, and 36 into the prioritized recommendations? Do we want to move forward with just number 35 at this point? Can I get some type of input from someone? I have Dr. Kamiar.
Farzad here. Yeah, so 36, when I was looking at that one, I sort of, it's in the realm of wordsmithing, hoping that it's sort of included in one other recommendation. The one that I can think that I put forward was the whole programs to monitor prescribing practices, essentially kind of capturing it here, but this is more than just training, but the essence of. So I would say yes for 36, but almost like 36 plus if it's not somewhere else that when it comes to pain management, I mean, look, here it is point blank, right? In the past 20 plus years, opioid prescribing is what got us into this, right? Huge mess. I want to reemphasize that. Opioid prescribing, right? Not someone going under a bridge to use heroin. It was, I got a prescription or someone had a prescription, right? And I will tell you, till this day, we still see a massive, right? Let's call it mismatch between evidence-based practices when it comes to pain management. Case in point, I still believe the #1 indication or ICD-10 or whatever for opioids in Nevada is back pain. And I'll tell you, if you go look at all the recommendations, they say, do not prescribe opioids for back pain. It's not indicated. It's not recommended. The evidence doesn't support it. And there's this path that you can go down, right? Rest, physical activity, heat, non-pharmacologic, then moving to stuff like ibuprofen and Tylenol, which work wonders and over the long term actually have favorable results compared to opioids, et cetera, et cetera. But every single day, someone's getting prescribed an opioid for back pain. And someone needs to be looking at this. So I was hoping to sort of capture that in the monitor prescribing practices. That's sort of what I meant. But if it gets lumped into this one, fantastic, or somewhere else. But there you go.
Yeah, well said. Thank you, Dr. Kamiar. And that's the way that I see it as well. Pretty much ditto on everything. You know, people can go to a pain management doctor today, and if they don't run it through their insurance, they pay cash. The doctor will give them what they need. That's my understanding. And that still exists today, even after and through the opioid epidemic. So that's just really concerning. Cornelius?
Thank you, Mr. Chair. Based on the comments that were just offered, I'd support moving forward the items in question in their entirety.
Thank you.
And especially given that they're going to be, that duplications will be looked at and things will be integrated, as Dawn mentioned. So
absolutely.
Thank you.
Elise?
Thanks, Chair. I just have a process question. So I think we're just moving forward. Well, how are we going to take a motion? Are you going to provide all of the numbers like we just did 34 or 36, 34, 33, but we also had done other numbers before this conversation? So what's the process for voting, moving these things forward? How are we keeping track of the numbers that we're discussing?
So everything that has been highlighted green, if it is highlighted green, then at the end of the meeting, and if it's not highlighted green, it'll be hidden. At the end of the this agenda item, we will move to approve by vote, and I'll be looking for a motion, all of the recommendations highlighted in green.
Okay, thank you.
I think we are in agreement for those ones, and let's move down to the next batch, which is 84 through, well, I know it moves into the next category of evaluate programs. We have been talking about it, so I'd like to group 84, 112, 143, 85, and 91 together. Elise, do you have another question, or is your hand still up?
No, sorry, I'm from my phone today, so it's just hard for me to keep track of what I'm doing. Sorry about that. Thank you.
No worries. Yeah, thank you so much. I just didn't want to miss you or anyone. So as we move to 84 through 91 on our recommendations, does anybody have any comment or questions, any interest in moving these ones forward? Pauline?
It sounds like to me that 84 already exists, and 112 already exists. So maybe we can not move those forward if they already exist, and those who are running 211 could
Okay,
amp it up if they need to.
great. Thank you. Dr. Cameo?
Farzad here. Yeah, 85 to me was somewhat similar again to, I think, a couple other, but basically, I mean, here's been my experience over the past 3 to 4 years. I think involved with members of this committee in this essence of how do we move the needle in regards to, let's say, call it a specific patient population, pregnant, postpartum individuals, reproductive age, sort of that demographic in regards to all of this, right? We've done amazing work, put together amazing kits and resources, et cetera, huge targets of those being delivery hospitals, effectively the stopgap for this patient population, right? I'm using heroin, I'm pregnant, I might not engage in regular care, but I'm going to end up likely delivering at a delivery hospital here in Nevada. And across that several years, we've spent a lot of time and effort to try to get hospitals to adopt some of these best practices, right? And the needle has moved. Let's get a microscope out to figure out how much it's moved, right? But then recently we came across this Zero Suicides initiative. And speaking with that staff and that initiative, it looks like they've made some serious headways in the past, not a lot of time, relatively speaking. So that's where 85 starts to hit for me, is these dedicated positions, offices, et cetera, that are specific to all of this stuff, to get all of this stuff out there, implemented, recommendations. That's the essence that I'm hoping to capture in this one and a couple other recommendations. Because what we've seen is when individuals can't dedicate their time and their efforts to this with follow-up, with engagement, all those sorts of things, healthcare system is slow. We don't do things. Best practices come out and something like 10, 15 years later, half the clinicians aren't even doing that still, right? And so I'm worried that without that, we're literally 10 or 15 years from now, we're still going to be having the same conversation and trying to figure out how to get overdose deaths to drop.
Absolutely. Thank you, Dr. Cameo. Are you looking to move 84 and 85 or simply 85?
I am in agreement. So if you look at basically 84, that captures a lot of what I was talking about, right? Specific to that population. But 85 is a little bit more broad, right? This position to coordinate these initiatives across the state. And I think we'll see bits and pieces in other recommendations as well to add to that.
Thank you, Dr. Cameo. Cornelius? I have you muted still, Cornelius.
Based on Dr. Cameo's input in my review, I'm supporting moving forward with 85 and 143. I think 143 is particularly important. I do have a question. I'm not familiar with the FRN and DO acronyms in the notes of 85. So if somebody could enlighten me, I'd appreciate that.
Thank you, Cornelius. Don?
Thank you.
Do you have a? This is Dawn, for the record. That's the Fund for Resilient Nevada in the director's office, which is the fund that we sit in currently.
Thank you.
So yes, let's highlight 143 and 85. I also have on mine highlighted 91. It just asks for an evaluation of outcomes and efforts for the substance use disorder treatments through criminal justice. And I think that it at the end, it really grabs me because it includes to determine best practices for improvements in outcomes. Right now, my experience has been that it is not it's helpful, but I just want to know what can be done to further improve these court or criminal justice programs to help individuals succeed. So if the committee is okay with that, I think we should also highlight 91. Pauline?
Thank you, Chairman. I also like 91. I'm in the juvenile justice system and work closely with our adult specialty courts. I think a lot of services happen in the criminal justice system that isn't captured, and effective services that's not currently captured, which is why I support 91.
Thank you. Cornelius?
Thank you, Mr. Chair, for the reasons that Pauline stated. I think 91 is very important, and also 91 allows for, it's an environment where data capture is pretty easy, and there's ways to extrapolate that data to other populations in it. So it's got public health ramifications that are really important. So I'd support 91 as well.
Thank you, Cornelius.
Thank you.
Dr. Camera?
Out here. Yeah, again, I think this is another one where I saw maybe overlap in different ways with other things, but basically, and especially since this is one of the SB 390 directives, right, the whole criminal justice system. My point here across the recommendations that touch on this subject would be this, that those involved with the criminal justice system are entitled to the exact same benefits as those that are not when it comes to substance use disorders, including opioid use disorder, which is a chronic disease, right? So in every which way that there should be parity, there needs to be parity. For example, criminal justice locations where patients aren't even offered medication for opioid use disorder. They just have to go through tough it out detox, or only certain formulations are offered, or aftercare planning is not done, and they might get it while they're involved, but then they're released and off into the wind. So that's sort of my recommendation when it comes to criminal justice, is everything, all the same stuff. Let's just call it parity.
Great points, Dr. Camera. Thank you. Don, can we get number 91 highlighted? Thank you. Cornelius?
Thanks, Mr. Chair. Just quickly, complete agreement with what Dr. Camyar offered, and I believe I recall seeing the issue of parity in that regard in another item, so that we may encounter that as we roll down, I believe, but I'm in agreement and completely with Dr. Camyar. Thank you.
Thank you, Cornelius. Don, at this time, I'd like to move us forward down to 94. Again, we'll take 94 through 100. If we look at 94 and you look at the notes, this is kind of already a must and is included. Kind of same thing that goes with 97. Seems to be a pretty close duplicate to 85. The note on number 100 seems to be pretty straightforward. I'm going to read through it. Keeping on steps through. Ideally, parity. There's the parity.
Mm-hmm.
And so with the note that we see inside of there, I say we move it forward, and the director's office can take what they will out of it, and I think it will have an impact as the state plan is being developed. Dr. Camera, this is one from you, isn't it?
Yeah, Farzad here. Yeah, all of these are mine.
Okay.
So 94 initially I provided that because I didn't know exactly what that was going to look like, but then the AG's office, I believe addressed that last time, right, as did Dr. Woodard. So 94 is totally fine to not be included because I think it's just part of the plan. Here we go, 97, that's basically what I was trying to say with this. We need someone to be looking at this stuff and ensure that there's coordination. So that was sort of a duplicate, maybe with a little bit different wording, but maybe more so along the evaluation side of things than it is the implementation or awareness side of things. And then 100, yeah, a lot there that I stuck in. But this is basically the point that I was trying to make is I think when we look at medical specialties, there is a preponderance of substandard, not ideal based practices that happen in substance use disorder treatment that I don't necessarily see anywhere else. So as an example, if I have diabetes, I show up to a primary care office, they check my blood pressure. They're like, we're going to check your A1C or your fasting glucose. Oh my gosh, you're pre-diabetes or you have diabetes. Well, here's our stepwise approach based off of these guidelines, right? We'll start with metformin, dietary, nutrition, we'll make our way to insulin, different formulations of, we will get this under control. Nothing like that exists when it comes to substance use disorder treatment. People will advertise that you can come to our center for 90 days and do yoga. We'll detox you. And then after 90 days, you are cured of your opioid use disorder and see you later. Or you'll see offices that aren't doing screening, brief intervention, or referral to treatment to identify that, right? Or they're using medications that aren't indicated or are not first line or are not indicated because they have ideal outcomes in a certain patient population. So it's just, it's kind of across the board, right? That we see practices when it comes to substance use disorder treatment that aren't on par where sort of a significant proportion of everything else is. Furthermore, from what we've seen is that like at High Risk Pregnancy Center, our mother program is SAPTA certified, right? There's other organizations that are out there that are SAPTA certified. They have IOTRC designations, all these designations. And I'm going to tell you, that doesn't guarantee quality at all. And this is a huge disservice to these clients because they're already traumatized, they're already stigmatized, they're already marginalized, right? And now they're going for effective evidence-based treatment that should be done the right way to a whole slew of other places that they're getting bombarded with when it comes to advertisements, right? Come to our detox, we're the best, blah, blah, blah. And holy moly, they're told things that aren't supported. And they're, you know, they're treated not with standards, right? Or evidence-based practices, all that hoopla that I just talked about. And then they might have a horrible outcome because of that, right? Their family this, them themselves that, their children this, and wow, right? Wow. So it's something that's been really frustrating for me in the field of addiction medicine is how horrible the quality is and how we're kind of okay with it as a medical system. We're basically okay with it. So I would really love for there to be an evaluation of these programs, especially those that are certified, that goes above and beyond and says, here's outcomes, here's the practices that are happening, there's all sorts of things that are going on that I don't know that anyone's doing anything about. And it kind of crushes my soul every single day. I'll conclude with that. It crushes my soul every single day.
Dr. Kamyar, thank you so much. I thought I was alone, honestly, and I'm sorry to take up the group's time. We have a lot of work to do, but I just wanted you to know personally, I am on the exact same level as you. I have experience as a person who has gone through these systems and a person who has worked in these systems to support people who are seeking services, and you are dead on point. It makes me a little bit sad to hear that you know it as well, because I thought that it was just one point of view and a perspective that I didn't get many people to align with or see. But hearing it from you really makes it that much more worse. But yeah, as I look at the opportunities that people have today to be seeking out services, and then what they find when they get there is a joke. And you know, one guy told me it exists because nothing else does. That's why it's here. You're right. It doesn't serve. It exists because there's nothing else better. That's the best we have, and that is truly sad. Because there is no way to have oversight besides the financial side and the bare minimum of safety and health. There's not really a best practices consideration whatsoever. So I'm sorry to get on my soapbox about that, but thank you for speaking on that, Dr. Kamyar. That being said, number 100 is highlighted and will be moving forward. Cornelius?
Okay, I'm also in favor of moving 100 forward, and I think the way that you and Dr. Kamyar describe things, it squares completely with my experience. And also it's so difficult to make a referral to these programs. I mean, I end up doing it basically on anecdotal hearsay that someone sent their kid and something worked out. It's just so difficult to know what's working and what's not. So I'm all in favor of have funds going toward program evaluation. I think it's critical. Absolutely. Thank you.
Pauline?
Thank you. So I'm in support of 100. 103 is what we spoke about before, is the parity for those involved in the criminal justice system. I agree, number 117 is already occurring with YRBS, and actually it doesn't even touch some of our kids who aren't in school, who are at the most at risk, so the YRBS doesn't even capture that data. And then I think that with number 72, with some of the criminal justice reform that's occurring, like release planning and case management, I guess the goal is for that to look different, because there are some new requirements within the criminal justice system with that. So I support 72 also. I just think some of that might be starting, like I think they might be developing some of that.
Thank you, Pauline. Yes, so I'd like to see number 72 highlighted at 103 as well. I didn't hear anything on 117, but it looks like it already exists. So with that being said, is that okay with you? Oh, sorry, Catherine.
Yeah, so I'm just going to say I didn't write 117, but the Youth Risk Behavioral Survey doesn't in particular ask school staff any information. It's in, randomly selected middle school and high school classrooms and asks students. I think that our substance misuse coalitions could do some work around asking school staff what they see and hear and what's occurring in schools. Because there is, I know for myself, there is a wealth of information that the teachers and staff do see, but I would agree with, I think it was Pauline who said that why there's a lot of students who aren't in school where this isn't answered. I just wanted whoever wrote that, and I don't know who did, but I mean, that is a resource, and maybe there are other ways that we could get that information, but I just wanted to clarify and make sure that people didn't think that the Youth Risk Behavioral Survey ever offered staff an opportunity for any input.
Thanks, Catherine. Karissa?
Yeah, I'll just second what Catherine said. So I have a lot of experience with URBIS coming from chronic disease prevention in public health work. So just to read it, it doesn't ask staff, and there's often things it's not getting from students that we want, because that is a national standardized survey. I'm not sure I remember all the time, but there may be questions you can add if you pay for them as a state. So it does cost money sometimes to add different questions. Maybe that's an option that can be explored with this funding. So I think 117 should go as a recommendation, because we don't get what we need from the YRBS to address what this is saying. If we're targeting staff, parents, and students, this particular risk behavioral survey is not getting us the information we need.
Great, thank you, Karissa. Laura?
Thank you, Chair. Laura Sherwood for the record. I did move that forward, and one of the findings is that through prevention programs that we've offered through middle school and high school, we're finding that the staff is very vocal about the issues they're having in their particular schools with substance use, and no two schools are alike. So they're very in tune with what's happening in their own schools, and it does differ from each school that we've been to.
Great. Thank you, Laura. Appreciate your clarification and the input. Looks like we're in agreement on 100, 103, 117, 72. It's hide number 97. It doesn't look like that was one that we agreed on. And if we could move down to the next batch, I would appreciate it. As we move down to the next batch, we are moving into the next legislative category, which is housing. We have 79, 133, 169 that fall under the housing legislative branch. In order to move forward in a timely manner, I'm going to group 126 through 79 together. And if anybody on this committee would like to speak on any of these or has a comment or interested in moving them forward as a priority, now is the time. Speaking of which, I have a note from Ariana, who is unable to be here today, that she would like to see 79 moved forward. And on the note, it also explains that 133 and 72 can kind of be grouped under 79. So Dawn, if you could highlight 79 for me, and then I'll take comment or input clarification questions from the committee.
Chair, may I? This is Dawn,
Dawn.
for the record. Since we did get the feedback from Ariana that she did want to see these three move forward, I would recommend the committee move them forward since she is your housing SME.
Thank you, Dawn. Let's include 133 and 169 in the highlighted. And Pauline?
Thank you. Sorry. I agree with moving the housing ones forward. I like 81 and 90. I'm just going to address 81 and 90 right now. I think that with like parole and probation officers are already getting there, because we've already had, especially your juvenile system, we've had reform for the last 10 years. So we've moved from the compliance world of just, here's your probation terms, do what you're told, to really the treatment aspect of making sure we're addressing the issues so we decrease recidivism. The adult system is just starting to go through that reform. So I like 81, I like 90, and I think some of it's already starting. It's occurring in the juvenile system, and I think it's beginning in the adult system.
Thank you, Pauline.
And one more thing, I'm sorry. If with introducing Matt into correctional and juvenile justice facilities, this goes back to workforce development, because we don't even have a MAT provider in our rural communities. And so we can do all these great recommendations, but if we don't have people who are willing to come and live in our rural communities that are MAT providers, then the rural areas still don't benefit from the funding. It goes to the urban and suburban. So I just want to put that out there, because we would love to have MAT services in our adult jail. We just can't get it.
Thank you, Pauline. Great points. Thank you. Queenie?
Queenie, for the record, I just wanted to say that I'm also in agreement with number 133 and 169. But if you can tell me what the acronym for NARR, the criteria, what does that mean? Then I can be for sure if I'm right for 169.
Does anybody have, I'm not sure what NARR represents. Can anybody clarify that for us? Came from Ariana.
This is Dawn. I think what they're trying to say is the National Alliance for Recovery Residencies standards.
Okay. Thank you, Dawn. I appreciate
You're welcome.
that. Okay. So yes, I'm in agreement with 169 as well.
Thank you. Did we see that we wanted to highlight number 90 as well from Pauline? Yeah. And 81? Or just 90? Yeah, it's kind of, yeah.
I like 81 too. I think I think you can build those together.
Thank you. Brittany?
I'm also interested in 139 as well, for the families, highlighting 139.
Yeah. Quinny, do you still have your hand up, or is that a new one?
Yes, I was supposed to put it down, but I didn't. But since you called on me, I was just looking at where it says work with parole and probation officers to educate the need for the treatment and recovery. I definitely agree with this because, you know, I've been there, and this helps a lot to be able to have this established in the community where they can be able to help those that's re-entering back into society and really don't know which way to go. So yeah, I'm for 81 too. Thank you.
Thank you. Looks like the committee is in agreement for 79, 133, 169, 81, 90, and 139. As we look at 37 and 116, I just don't know what 37 is going to look like in practical application. I mean, that's kind of the goal of all that we've included so far is to, you know, abate the damage that has been done and support the further treatment and supportive services of people who are experiencing opioid use disorder or have been affected by the opioid epidemic. So that being said, to have funds for this committee to recommend that funds be directly committed to prevention, screening, and treatment of ACEs seems pretty broad and kind of out of the scope of the specifics of this committee, but I'd like to hear from anybody that would like to speak on 37 and 116. Pauline?
Thank you. When I look at the ACEs screening, we do ACEs screening in juvenile justice. So, I mean, I look at that as a localized agency or treatment centers. That's one of the assessment tools or risk tools that they use. If that's the area that they deal with or address. I mean, I guess for me that's really specific in this big world that we're in. It would look different to me if it said like identify reliable and validated screening, prevention and screening tools, and it just wouldn't be the ACEs. But I think that a lot of agencies use the ACE already, so I just wasn't feeling that one, I guess is what I'm saying, to move forward.
Yes, thank you, Pauline. That's kind of where I was also. That being said, if nobody has any more comments about yeah, thank you, Don. Same thing goes, Dr. Kimra?
Yeah, Farzad here. I see that 116 talks about schools specifically, but my understanding is that the ACEs screening can be done by the parent, caregiver, teens as they get older, etc. And I don't know if this is a universal practice or if that recommendation actually exists to be a universal practice in that pediatric setting. You know, like I'm familiar with substance use disorder stuff, right? But not so much ACEs. I understand the importance of ACEs, and I think that's explicitly why they call it out as an SB 390 issue. But my guess would be something similar to how we talk about SBIRT for substance use. This is basically SBIRT for adverse childhood experiences. Mm-hmm. So yeah, absolutely. I mean, even if it's not a recommendation, my best guess is that it's probably much like how screening is sort of the best way to identify. Same thing here.
Thank you, Dr. Kamyar. Brittany?
I think there's some, I'm not certain it's an ACEs screening tool, but there is a tool that a lot of the schools utilize at the beginning of the school year, from elementary up to high school, to identify like if children are experiencing any changes in their lives, any emotional things, and they actually will meet with the counselor depending on how they score on those screening tools. I'm not certain, it's not an ACEs, I'm not sure exactly what it is, but there is something already in the schools similar to the ACEs screening.
That being, Catherine?
Yeah, so I mean, there are places around the country that are looking at ACEs. We look at early warning systems and risk indices and apply information that we have. And I think there's a lot of great things happening with ACEs, but ACEs, it doesn't comprehensively include everything that we all would consider an important risk indicator for kids. For example, if someone's had death, grief, and loss of a parent or a loved one, that's not measured or included under ACEs. So, I mean, I think things that involve, planning and comprehensive prevention and examining tools and resources or statewide efforts are important. I'm more interested in implement trauma-informed schools, and I see that someone has indicated, which is true, that there are statewide efforts around trauma-informed schools or trauma-sensitive schools, but that is something that would help all kids, that never is harmful to kids, that's inclusive of kids. And so I think that would be, if we were going to put our efforts into the instructional practices and the direct support of students inside a school, that we would yield great results. So I just wanted to say, since you were all talking about the ACEs, just mention some of those issues. I think we have some work to do in schools to systemically across the state of Nevada utilize ACEs screening.
Thank you, Catherine. Dr. Kemner?
Sorry, far as I hear, I'm lowering the hand that I forgot to do earlier.
Oh, thank you. So that being said, I think we can hide 116, highlight 126 through 145. And unless anybody has any disagreement with 126 through 145, we should be able to move forward. Pauline?
Yeah, I guess for me, the implement trauma-informed schools, like the first step. I mean, we can identify trauma, but how we respond to it is what makes a difference. So, I mean, if that said, implement trauma, not just informed, but responsive, because I think it's easy for the school system to go through trauma-informed training and call it good, but how we respond to that trauma is really what makes a difference with our kids.
Absolutely. Thank you, Pauline. You know what I'm noticing after this conversation is you often hear police are not social workers. The teachers are not social workers. Well, it's not that we need them to be social workers. We just need them to be human. We just need them to be considerate of something outside of their direct role, to consider this person is hurting, and now where can I get them connected to? That's all it sounds like to me. And it looks like we're getting in that direction. That being said, we will move forward from 145 down to 74, 75, 76, 104, 105, 106. And does anybody, now we're in the legislative category of reduce harm. Does anybody have any comments or questions, or would like to see any of these move forward as a recommendation by this committee? 6. Oh, this is a big one, right? Harm reduction, which is I think I have Pauline first and then Catherine. Hard to tell.
Thank you. I just think the number 75 with the Naloxone kits, like our local coalitions do an amazing job in training and distributing those. And I don't know if that funding is going away for those kits, but I mean, our local coalition, our rural coalitions, I'm not sure about, I would think PACE and probably JTNN do it too, but they're doing amazing with the training and distributing free Naloxone kits, and not just to agencies, but to community members or whoever wants them. So I feel like that might already be being done, unless that funding's going away. So I support it. I'm just not sure that it needs to be one of our priorities moving forward.
Okay. Catherine?
I thought there was a lot of good ones in here. I really think the prevention services rooted in harm reduction principles, and I know this is related to some of our others. I thought that was an important one. And I know that's related to some of the others also that we have, and I see a relationship between many of them. I see that under family support groups, it says the recommendation is incomplete. But in my work in schools, what I see as a continuing need for families is someone to go to and someone to work with, whether that's, peer support groups or groups that are facilitated by providers. It's just, that is something that it seems that we should definitely prioritize because people who are navigating through the system need to know other people who are navigating through the system or other people who have reached a different place in the system. And one of the biggest concerns that I hear from parents, from teachers with loved ones with substance misuse, there needs to be, this needs to be something that is always available. I really believe that.
Yeah, absolutely. My experience is very similar, and the little bit of work that I've been able to do with schools and school groups, specifically social workers and administrators, I've always been trying to implant in there peer support. If you had a group or an individual that could help these families as they're going through substance use or behavioral health issues, if you had somebody who was a peer support worker in there, it might not be as daunting to speak with them as it is to speak to a social worker where you feel like you might be in trouble and you're going to need to be checked on. If you had somebody that you could relate to, it might be a little bit more productive. But that being said, it sounds like Catherine would like to see number 104 highlighted. Thank you for clarifying, and Dawn for adding some additional verbiage in there. The way and reason that Dawn is able to do that is because this one has not gone through the objective tool, so it will be denoted on the recommendations specifically that this one has, if they have not been pushed through the objective tool, they'll be marked as such. That being said, it sounded like Pauline was recommending 75 and 74. So we could highlight those two. And then I have Dr. now. And then, yeah, I don't know. Dr. Cameron.
Was on here. Yeah, so this is the whole, like, are we creating recommendations sort of independent of what is already in place, whether this is going to supplement versus supplant, it's not supposed to, et cetera, et cetera. But when it comes to sort of, harm reduction is this huge model, right? A lot of things we've been talking about are actually fall under the umbrella of harm reduction, right? All these stigma stuff, educational campaigns, it's more than just naloxone needle exchanges, but things like when it comes to opioids, naloxone needle exchanges, safe injection sites, fentanyl test strips, they are sort of fundamental. So I think we should be recommending them. Now, whether the funding comes from somewhere else or whatnot, or if the funding runs dry, and so then they need to rely on opioid settlement funds, it's sort of a must.
Good points. Good points. That being said, I just feel like 74 is redundant, and we kind of grasp that in 75, so they're pretty much the same. But what do you guys think? Leave 74, take 74 off? Do we need to add 76, 105, or 106? Any comments or questions? Karissa.
So I do see when I read them, 74 and 75 as being slightly different. 75 to me is very focused on naloxone, while 74 is about comprehensive harm reduction prevention strategies and determining and implementing those. So I would keep both, is my comment.
Okay. Yeah, I see what you're saying, and I doubt that 75 is going away, but just to make sure it's grouped in, I guess we'll do that. I mean, I don't hear any support for 76, but in my part of the state, I don't think that we have enough of this. So I would advocate for the committee to add 76. But that being said, 105 is kind of what Dr. Kamyar was bringing up earlier, and what will it look like in practical application. Maybe it'll be more of an emphasis to shine some light on the fact that many, not all service providers for behavioral health and substance use are using best practices. So a requirement, I don't know who would oversee that, but I guess just to mention it would be important. The idea on 106 is also, I think, critical. Remove silos between public health practices and harm reduction services is genius, and I think that could be beneficial. Don, we just had a change in the Zoom, which had us lose a little bit there. Oh, I guess it doesn't. It was fine. Yeah. That being said, does the committee want to move forward with 76, 105, and 106, or are we just good with 74, 75, 104? Pauline?
Thank you. Again, I think 106 is already available. I mean, we use it through CASAT and SAMHSA. We use national organizations to do that. So I didn't have my support for 106. I just felt like that was already available.
Okay.
The other ones I'm in agreement with.
Thank you. Dr. Kamya?
Farzad here. So 76, super controversial, right? But when it comes to an evidence-based practice, it's included in, we see it as we do when it comes to harm reduction, like naloxone, like fentanyl test strips, et cetera, right? But again, it's probably one of the more controversial pieces of a harm reduction strategy. However, if we're going to sort of set aside whatever we want to call that, biases, et cetera, I would say we should support the essence of harm reduction, which includes things like needle exchange and safe injection sites.
I absolutely, I agree with you. And it may be challenging at sometimes, but in this case, I'm with you. Whatever the bias may be, best if we go with evidence-based practices. So this is a leader, and I think it'll help shift the general view of harm reduction as we get something as controversial as naloxone pushed forward. So Dawn, if we can get you, Pauline's your hand up, new or okay, thank you. 76, please highlight number 76, and we'll do 105, but we'll hide number 106. Is everyone good with hiding 106, or did that one? I think we had one comment and we're comfortable with that. No hands up. Thank you, Don. Again, 76 and 105, and then we will move forward to the next batch, starting with 107. All right. 107 through 167, all in reduce harm legislative category. Do we have any comments or anything like that? Pauline?
Thank you. I'm just wondering about 109. Is that not happening? I mean, are law enforcement officers arresting people who like go to the hospital or ER or the friends who call for an overdose? That I mean, it doesn't happen in our jurisdiction, so I mean, it's a statute.
I don't know, but I think that there's general like unsureness of if I'm going to get in trouble for trying to help someone. So I think that it can be discussed. Karissa?
Thanks, Chair. Karissa for the record. I'm just wondering if number, hold on, 108, is that substantially different from the one above that just got highlighted that had naloxone called out? So I don't know if that's duplicative or not, or worth sending forward if it's substantially different intention.
Yeah, thank you for the comment. And yeah, so that being said, I think we can leave out 108. And I think that the difference is, prioritize someone who's at the highest risk. Is there, how does that, right now, my understanding of naloxone distribution is those that want it can get it. They have to seek it, and then also with situations where people who work in the community have it on them, they can distribute it as someone asks for it. But prioritizing a person, well, I mean, I guess I can see how it might come into effect. We providers see someone who's at the highest risk for overdose and says, I just don't think that the prioritization needs to be there. They're not going to say, I have two, you're higher than this person, so you get it and you don't. Dr. Camillar?
Farzad here. Yeah, it's probably beneficial to have this essence of, let's call it quote unquote best practices when it comes to naloxone distribution and prescribing. I can think of a few things, right? Like if you're writing a prescription for an opioid, best practices to, provide a prescription for naloxone. If someone's using polysubstances, if someone is engaged in medication for opioid use disorder or substance use disorder, I mean, there are instances where we should be doing it, and then instances where we could be doing it. That there is this. We've worked with the Board of Pharmacy to clarify this, but basically, pharmacists can distribute naloxone without a prescription, right? But there's a significant proportion of those that don't know that, right? Both from a public and from a clinician side of things. So the prioritization, maybe not so much, but that's, okay, here's some things that we could be doing when it comes to naloxone. And I think the reality is, unfortunately, that I don't know. I mean, I might have a good idea on who is most at high risk for overdose death. But what we're seeing is that fentanyl is in everything, including cocaine and cannabis. And if you are opioid naive, or it's just fentanyl to begin with, then you could use cannabis and overdose and die. So it would be hard to recognize that, right, as a priority.
Thank you, Dr. Camillar. Karissa?
Yeah, thank you, Chair. Karissa, for the record. So, thank you, Dr. Camillar, for further providing context. I would add here, so is this back to 108, because I'm just kind of stuck on it. Is it more of a data recommendation, though, in that we need to get that systematic data that could drive that allocation, that could help identify the way Dr. Camillar has described, so that we could prioritize naloxone distribution to people at highest risk? So maybe it's reduced harm, but it also seems tied up with the data components, because it seems the underlying recommendation is that we need better data to better prioritize finding those at highest risk of overdose.
Yeah, so I see your point, and I hear where we're going. I think that if we keep it, I guess it boils down to the SMEs that know, is that a priority if we look at it from a data perspective, that we want to push forward. That being said, kind of like what Dr. Camero was leaning towards. It makes it challenging to prioritize the distribution based off of risk. So do we want to push the state plan to start getting involved with who is the highest risk based off of data and get that funded so that it's more comprehensive and utilize that in a broader way, or are we okay where we're at? I don't know if I said that right, but I think I got that out. So I guess then what I would be looking forward for from here is, do we want 108 highlighted or not? Laura?
Thank you, Chair. I guess for the committee, my question is there a need to prioritize naloxone? Isn't it readily available through the health district or those who ask for it? I'm wondering why there would be a need to prioritize. It should be available, I believe, to any person that asks for it.
Yep, and that's where we currently sit. That being said, I don't think that we need, well, I'm not hearing, my personal opinion is that I don't think that we need to move 108 forward, and I would like to hear from the committee if they're in agreement with that. And if not, then we can highlight it and move it forward. Pauline?
I'm in agreement with not moving 108 forward. I think that it's already there, and we're going to have so many recommendations. I think we need to be really cognizant of that, that what we already have implemented, we strengthen that and not move up our priorities to supplement that. And I'm still stuck on 109 that says require the protections from 911 Good Samaritan law. There's no requiring anything. It's NRS statute. It's if someone goes against NRS statute, that can be addressed in the legal system. I mean, there's to me the requirement it is required, period.
Thank you. Laura?
Thank you. So in regard to 109 and 110, I do believe that we have some current cases and we don't have established case law just yet. But for example, with a person that does have a small amount of drugs, maybe it is a couple of pills that contain fentanyl, they're aware that it contains fentanyl. They provide that to a person. That person dies from that dose of fentanyl, that pill, but they remain on scene. There's a question whether or not there's some liability of that person. Are they protected against the Good Samaritan law when they knowingly gave that pill to the person that died of an overdose? So I don't believe we have case law and clarification of that statute for the Good Samaritan law, as well as other statutes that actually conflict with the Good Samaritan law.
Thank you, Laura. Before I take the next two hands, I'd just like to let it be known that the surge group is looking into 108 and 109. Oh no, sorry, 109 and 110. And that there is some confusion about what that looks like. And as far as we move forward on this committee, I'm not sure what subject matter experts we have that would like to see 109 and 110 move forward. But I think that the broadness of 109 and 110, we could talk about it for in depth and add them or not add them, but I think I would like to advocate for this committee to move 109 and 110 as hidden and have them addressed through surge, the surge committee. If there's opposition to that, I'm fine with talking about it. And if we are going to move 109 and 110 as hidden, then do we want to move 108 also as hidden? Cornelius.
Thanks, Mr. Chair. I agree completely on 109, 110. Regarding 108, there's some language in there that I think is important with regard to equity as well. So and that's, we're looking at communities with high death rates and innovative efforts to connect with people at highest risk. I didn't author this recommendation, but people who are housed living alone in settings where drug use is hidden, I'm not sure we capture that with some of the other recommendations. I'm not sure. And I think that might be an important part of 108. With leaving 108 in there, I'm really curious what other people think, or if, about that idea. Equity and then reaches to people who normally wouldn't have access. Thank you.
I guess the difficulty for me on this one is that the beginning, prioritize naloxone distribution, already done. People at highest risk, complicated because of data. This will require more systematic data collection. If the data collection is adequate, then we don't need to add more to it. If it's not, then I guess we should. After that, allocation of resources towards people and communities with high death rates, absolutely. That's what kind of flips me back to. We must include it. So it sounds like Cornelius, to me, it sounds like you would like to see 108 move forward, or is it more just a clarification question?
I'm leaning toward moving it forward because of that part, but I see it the same way you do. And so I'm not super committed to moving it forward. I just hope that somewhere as a committee, we capture the portion of 108 that talks about the importance of driving resources to people who otherwise wouldn't find those resources, and communities most at risk.
I think in the sake of having a limited amount of recommendations that target that issue, that we ought to include it, because that would just be awful if there was this was the only one, or there were limited that were targeted towards that specific portion of the recommendation. Laura?
Thank you, Chair. With regard to 108, I know that the Health District, Southern Nevada Health District, does have a mobile unit that does go to rural areas and some of the areas that have been identified to have issues with substance use via the OD mapping system. So I don't know if folks are aware of that. Does that help to answer that question?
Yes. And so something already exists. It is working, but the portion about systematic data or more systematic data collection, I think is the part. So this one's just all kinds of got us wrapped up here.
Yeah.
Pauline?
Well, I mean, I think that that's just a broader topic. I mean, that's a broader thing that we're trying to do in many of these, and that we have addressed. So to me, or that we can add to something else, that we hide 108 with the caveat that we still want to be able to go to those places where data shows us. But I think there is some data mapping occurring in areas. I mean, we don't have a mobile unit that comes up to our rural area, but we're doing some data mapping of our own. And so I think we're stuck on the prioritizing naloxone, but there are good pieces of that we can add maybe to our data system needs overall.
That being said, this is one that has not been through the objective tool. Why don't we start with require more systematic data collection and take out the first sentence, and then we can push it forward. Don, is that something that we're able to do? Cornelius?
Thanks, Mr. Chair. I agree with that suggestion you just had, and agree with what Pauline has said as well. Pauline, I'm sorry.
Thank you. So Don, what we're looking for is right where it says this rule require, we just start at require a more systematic data collection. It's a capital R. Yeah, okay, perfect. That works. Let's highlight 108 Now we're looking at 107, 111, 114. So I think we can hide 114 because we talked about that prioritized naloxone distribution over and over. And the people in those MAP programs are people that have access to. Is the committee comfortable with that? It was just hidden. I just want to make sure we're all good with that. If there's any comments and that one needs to be brought back up, please let me know. As far as 107 and 111, I haven't heard much conversation on either one of those. Are we good with moving on and hiding them, or would we like to add them as something to be looked at? Ooh, an advisory board, a state advisory board that implementation. I mean, I just don't think there's enough harm reduction services or just looking at things from a harm reduction perspective, but that's my thoughts. Pauline?
Thank you. I look at it, again, the word establish always scares me, and especially with advisory boards, because I just sat through a sunset committee that was sunsetting lots of advisory boards. And I think that as we prioritize, there's not going to be anything to advise on until we get these going, as for like data outcomes and things like that. And with any grant funding, to me, that comes with it. There's the evaluation piece that is built in, and maybe whoever gets funding does a outcomes report to the state agency. So I didn't have this identified as something that I wanted to move forward. I just think that we don't need more layers on the top. We need more services on the ground.
Good call. I agree. And thank you, Don, for moving that one to hidden. Laura?
Yes, with that one in particular, it looks like we've covered that in either 74 or 75. So it seems like it's a bit redundant.
Thank you, Laura. 111, how do we feel about 111? Pauline, is your hand still up? Laura, is your hand still up? Thank you, thank you. I mean, this one I'm pretty sure was from Dr. Wagner, and I know it's brief, but I think that it's along the same lines as the controversial nature of needle exchange programs. Safe drug consumption sites are, contested and controversial, but I don't know. I think they're what's it called? Studied and considered like positive, to give positive outcomes and are maybe best practices, but I have no idea. Darcy.
Yes, thank you, Darcy Patterson, for the record. I think that since we already have evidence-based practices on the establishment of supervised drug consumption sites, that we need to have funding for that. I mean, it's obviously proven that they work and that they need to be implemented. And I think that would save a lot of lives, even though it's very controversial.
Thank you, Darcy. Cornelius? Oh, never mind. Oh.
Thanks, Mr. Chair. Sorry about that.
Oh, you're good.
Balancing act between the background noise and being with all of you. I'm in agreement with what Darcy said, and I think the movement forward of 111, it's an important like sentiment for the committee to be behind that. We're looking at things that are known to work, even though they may be controversial. We know they can save lives. And that's what we're about, despite the controversy. So to not shy away from 111. So I'm for moving 111 forward.
Thank you. We have, yep. Thank you, Don, for highlighting that one. And I'm with it. If anybody is opposed or sees an issue with that, please let us know now. I don't see any hands up, so I'm going to move forward to 155 through 134. This comes from a state agency 155. I don't know what that looks like in practical application, and I'm not really too informed on the nature of the recommendation, but if somebody in this committee would like to see it move forward, I'd like to hear from you now. If anybody have any comments on any of the others, 167, 89, 98, 99, and 134. Dr. Camera?
Farzad here. 89, 98, 99, mine. I proposed those. And this is all surrounding basically, let's call it best practices to reduce neonatal abstinence syndrome. Again, this is one of the SB 390 directives. And there's a couple things here that would really help reduce that, but are just not being done, right? So this whole essence of SBIRT and things that come down the line with that is not happening, whether in our primary care OB offices, but also at the delivering hospitals and healthcare systems in general. So that's where the importance of all this stuff lies. And this was like really targeted with the efforts that have gone on by like the Omni-ASTO groups, the PRISM groups, et cetera, over the past several years. So this is just another way to highlight if we want to move the needle when it comes to reducing neonatal abstinence syndrome, we're going to have to look at things like this. Specifically 99, that's more of an evidence-based practice, just point blank, buprenorphine versus methadone. Methadone is probably used, I'm just going to throw it out there, I don't know, something like 99% of our reproductive age patients that end up getting pregnant, right, and delivering. And when you compare the two medications of buprenorphine versus methadone, I'm pretty sure the evidence shows that it's unequivocal which one is better for the neonate and when it comes to neonatal abstinence syndrome across the board in numerous ways. But we are not there. We're not there despite our efforts, education, et cetera, et cetera. And let me tell you, this is happening from our agencies that are the predominant treatment agencies here in the States, where the majority of these patients present and go for treatment. So these things would be really important. We have toolkits that from an outpatient perspective, from an inpatient perspective, that basically highlight what to do, how to do it, who to do it for, et cetera, across the board when it comes to other things. This also highlights care of the neonate, because, so let's talk about care from the patient perspective. There's things that can be done there, like I said, buprenorphine, screening, et cetera, but then there's also things that can be done from a neonatal perspective that again is not being done. American Academy of Pediatrics and others have recommended things like the Eat, Sleep, Console model, which is different than the traditional model that's being used to treat neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. How to monitor, how to treat first-line treatments, which are all not NICU and not medication-based, but you will be hard-pressed to find a birthing hospital here in our state that uses those principles. So again, it's just an injustice. It's an injustice to this patient population, and it's an injustice to the dyad that includes the parent, caregiver, and the neonate. So sort of lumping this into, again, those offices, the positions that support or prioritize engagement, education, et cetera, across the board. Because we have very effective ways of reducing this stuff. We just are horrible at doing it.
Great, thank you. The chair had to step away for a second. So Cornelius. You're muted.
I'm sorry, you guys, thanks. I would recommend to the committee moving recommendations 89, 98, and 99 forward.
Okay, this is Karissa for the record. Chair had to step away, as Don said, so I'll take over as vice chair until he returns. I agree with that. any other, Darcy, go ahead, please.
I work in the labor and delivery department, and I am for moving forward 89, 98, and 99 from what Dr. Kammer said.
Thank you, Darcy. I agree as well. I think that's a very important population to target and address for this issue. I think I saw someone else's hands raised, but then it went down. So just want to make sure you didn't. Laura, go ahead, Laura, please.
That was me.
Oh, Cecilia. Okay, well,
just indicating I do concur with moving those three forward.
Thank you. Appreciate that. Cecilia?
Yes.
Thank
Hi.
Hi.
I just wanted to say I'm in total agreement. For years, I was called to pick up infants from various hospitals and never received any support for the infants going through withdrawal. I took classes, etc., but nothing really pinpointed. So I am in agreement with those three.
Thank you, Cecilia. Okay, so I think we've heard a general consensus and at the very least, no strong opposition to 89, 98, 99. Did we have comments as a committee or thoughts on 155 and 167?
Sorry about that, team, I'm back. Sorry about that.
Oh, thank you, Chair.
Thank you,
May
Chris.
I go ahead with a comment on 155?
Please. Then I'll
Thank
call
you. Karissa, continuing for the record. So on 155, I'll say from my public health implementation subject matter expertise perspective, I think what they're trying to get at is, so we're definitely going to have more information about things that ended in death, unfortunately, than we are about the situations that do not end in death. So obviously, if this has been recommended, in my mind, from a state agency, that we need a disease investigation model to study non-fatal overdoses. So to be able to find people who overdosed that did not, end in death, and maybe not even hospitalization, or that's going to be hard, right? If you didn't touch the formal medical system, can we find information about your overdose, how it was reversed or prevented, etc. So I think that's what they're going for there. I think it's important. I'll say that. So that's my comment on that. Thank you, Chair.
Thank you, Karissa. Cornelius?
Thank you, Mr. Chair. I would recommend to the committee moving recommendation number 155 forward.
That being said, 167 is another controversial one, but does align with best practices. And as we kind of talked about, it isn't being implemented here in Nevada, but it is a harm reduction prevention measure that does yield positive results. I move that we add 167 to the recommendations as well. Can I get anybody to? Thank you, Darcy. Floor is yours.
I agree to that. Also the 167, but I also know that they are using that in Southern Nevada.
Oh, sorry about that. Thank you.
No worries.
Let's move down to 134, 135, 136, and 137. These, as the notes say, these kind of align with 98, 99. I didn't see 29. Oh, that's 29 needed to be broken down. Yeah, I don't understand why the Esper.
Chair, sorry, this is Dawn for the record. Just ignore our notes over here. It's kind of a little bit of a mess. Number 98 was the one you guys just reviewed a little while ago with Dr. Kamiar with the evaluation piece. And so just kind of ignore our notes right here.
Thank you. I don't know what incentivized looks like, but I guess the point that I was trying to make is I don't see how Esper is not, a common starting foundational point with all health and even behavioral health, social services um, settings. So I think that I don't know, we're not going to wordsmith, but we are going to, I think that we should just highlight that need for expert in all settings, specifically and especially OBGYNs. Because this one specifically mentions OBGYN, I wonder if we don't add it because we kind of already have it. Would anybody like to speak to that? Pauline?
I agree, Chairman Sanchez. I think that expert is beneficial in lots of different areas, not just OBGYN. So, and I think we addressed that earlier on with the expert, that's one of them that could be used.
Thank you. Dr. Cameron?
Farzad here. Yeah, my guess is this got called out for OB-GYN settings because it would be a direct way to reduce neonatal abstinence syndrome, right? Versus what we're talking about more generally.
Thank you. Cornelius?
My comment's the same as Dr. Camiar's.
So we do want to see it move. Oh, sorry.
Given the category we're dealing with, Mr. Chair.
Okay. So we would like to see it move forward then, is that correct?
Cornelius, I believe it would be wise to do that, even though it's parceled off to one area of medical focus. I think it'd be wise to move forward.
Okay. What about 135, 136, 137? Oh my goodness. I'm a big advocate for the 135, but Pauline, is your hand still up or is that a new hand? Oh, you're good. Brittany?
I'm in support of 135. I think having someone help someone with a opioid use disorder navigate that would be very helpful as far as trying to parent and encouraging them to stay on the correct course of sobriety.
I don't know thank you so much, Brittany. I don't know what 136 and 137 look like in practical application, but we have the note of feasible already occurring, but not to scale. That being said, I think it falls in alignment with what this committee is concerned with. And that being said, we should move it to highlighted and included in our recommendations. If there's any questions or concerns with those two being moved forward, I'd like to hear them now. If not, I'd like to move to 108 through yeah, there we go. Allocated. Karissa.
Thank you, Chair. Karissa, for the record. This is just, I'll reiterate, this is something, again, my new recommendation there. It is a holdover from something else. So I think you can hide it. It's in one of these other long worded.
Thanks, Karissa. We have 12, 13, 18, 21, and 25 on the board right now. Any committee member want to see these move forward? I don't think I mentioned it for the record, but I did just want to add it for the record. Ariana Saunders did join us and is present at this time. Dr. Cameron.
Yeah, Farzad here. So number 12 is one that I had recommended, but again, this is in line with the whole, right? So we're specifically calling out non-pharmacological interventions, right? We're looking at pain management here. But again, I under the umbrella of what are the best practices when it comes to pain management, right? Someone should be looking at that and seeing why this stuff isn't happening. So I think that's the essence of that one right there.
Yes, that being said, I think it needs to move forward, but we're into the complication of what that looks like moving through the state plan, but I think it needs to be addressed and looked at as well. If we look at 13, this is another one. Is this one from you also, Dr. Kenner? No, it isn't. Huh? Any thoughts on 13, 18, 21, 25? Treatment access. I mean, we need to expand treatment access in rural or underserved areas as a whole. But how does the state encourage non-traditional community resources such as churches? Oh yeah, that's the spoken hub model. We talked about that. Yeah, I don't know what it looks like, but we should advocate for it to be happening, right? If we could make those connections and at least start the path, plant the seed that this is where the state is going, that'd be excellent. Little Nietzsche?
Hi, I'm in agreement for 21 and 25 also.
Yeah. Pauline? Thank you, Little Nietzsche.
Thank you. I think youth mental health first aid is already being used in school settings. I'm not sure if that's statewide. I know it's mandatory for our school district here. I support 21. Honestly, I read 25 and I'm like, what does that mean? So can't support something that I don't have a clear picture on.
Right. And I just think that we should be using the PDMP in a different way to kind of like, what's it called? Oh, have some oversight on what's being prescribed and how much of it. But just anything to do with PDMP is I'm a little foggy on as well. Dr. Cameron.
On here, yeah, I would prefer to see the wording of number 25 changed to keep the polysubstance use, but identify trains in, let's call it controlled substance prescriptions, because you know, theoretically speaking, directly reading what this says, stimulant prescriptions issued and dispensed. The reality is the majority of stimulant prescriptions are for ADHD, right? And I actually don't have a problem per se with someone being prescribed Adderall, right? And so I'm not sure that that's the actual issue versus benzodiazepines, then don't get me started, right? So I'm not sure if that's what this was supposed to say, but maybe just keeping it more generic, like identify trends in controlled substance prescriptions issued and dispensed.
Good call. Thank you for making that suggestion. Thank you, Dawn, for adding that to the notes. I'd like to ask that the 18 be hidden and not move forward. I just don't like MAT providers incentives for participation for patient-centered. I mean, that should be a baseline. That should be a foundation. I don't understand how, I guess, not that there should be any change, but if there was, it would be oversight to include that all MAT providers are participating in patient-centered treatment. Moving down to number 28, 29, 38, 39, 41. Do we see any there that we're interested in moving forward? So I mean, I can say that 28 is happening, right? I mean, fully implement, I guess, takes time, but the idea of it's in of itself, zero suicide framework is being implemented. Dr. Cameron?
Here, yeah, I guess for 29, I'm reading through the others, sorry, but I'll comment on 29. You know, when we talk about disease prevention across the primary, tertiary, secondary, et cetera, for all intents and purposes, let's call 29 one of the most important things when it comes to identifying and treating substance use disorders. To make an analogy for other chronic disease management, I'll basically say that this is like going to your doctor's office and them never checking your blood pressure, right, to look for hypertension. That's effectively what we're talking about when we say expert for substance use disorders, right? Because it's the best tool we have. I don't know of anything else. Some agencies are engaging in other practices, which like universal urine drug testing. There are huge issues there, and that's not what we mean. But when we talk about expert, we talk about asking people questions.
Thank you, Dr. Cameron. I agree 100%. Cornelius?
Thank you, Mr. Chair. Agreement with Dr. Kamiar on moving 29 forward, and then commenting on recommendation 38. I think 38 is really important to move forward. I believe I recommended another thing similar. And the primary thing, it's access to those kinds of services that gets blocked. And so it sort of ties into a legislative question where insurers, I'd mentioned to the committee before that insurers are not reimbursing family-based services or dyadic therapy services on par with individual psychotherapy for those of us providing those services. That's what we're noticing. And I think 38 starts to speak to that. To enhancing access to those services. There are other issues in 38 as well, where some underserved communities or communities that don't have access to, let's say, online therapy, things like that, might start to have that access with 38 move forward.
Thank you. Thank you, Cornelius.
Thank you.
Are we comfortable as a committee hiding number 28? And how do we feel about number 39? What about 41? I think that 41 kind of ties together with 38 or 28, which we just hid. The state is currently working towards a zero suicide programming or in that direction. What do we think about 41 and 39? Add 50 to that as well. Cornelius?
Thank you again. Question on 39, and maybe Dr. Kamiar could speak to it. Do we need a telemat service provider?
Yeah, so this is a tricky one. It's basically, how do we expand services to, let's call it rural, frontier, etc. That's tough. I don't know that we need to partner with a telemat service provider. A lot we offer telemat services, right? Basically, and we're seeing that practices that provide these services to begin with ideally have implemented something, especially through the pandemic, to provide these services anyway, right? Via tele. The biggest issue I see with this is when the COVID-19 emergency status is lifted, then the Ryan Hott Act, which is a DEA limitation to basically prescribing controlled substances using telehealth, will theoretically go away, and you can't do that anymore. You can do it on a continuing basis. Long story short, your first visit needs to be in person, right? So if I'm starting someone on buprenorphine, I technically have to see them in office, face-to-face, in person. But it's interesting because it's potentially that we need to make some modifications at that level, because we say that telehealth is similar to face-to-face interactions, right? And that's how we're treating it from a parity perspective. So I don't know. I mean, I was trying to look into some stuff. I think I provided maybe some notes on a recommendation that there is something about the tribal, they don't have the same laws, et cetera, as something that we could utilize. But I don't know that we need to partner with a telemat provider on this one. So I would be inclined to say no.
I think I'm in agreement with Dr. Kamiar. A specific service provider may not be the answer, but the premise of telehealth in general, as long as it follows the requirements, that first meeting in person and then continuation of medically assisted treatment for substance use seems to be in order so far, but I'm in the same direction, inclined to hide number 39. Pauline?
My apologies. I had something and I lost it. So I'm just going to lower my hand.
Okay. When you're done coughing, let us know. 41, 50, 51, 52, 53. Any comments? Just, I don't see how 41 can hurt, but I don't know what it looks like in practical application. This one from 50, is this from you, Cornelius?
That's not, Mr. Chair, I don't believe. No, it's not.
Okay. I'm not sure what it looks like to have prior authorization as a barrier to services for the purposes of our recommendations, but if anybody can speak to it, I would appreciate it. Brittany?
I'm not certain it's a barrier. I think it's just more paperwork to these services, but I think to take away the need for prior authorization for typical group therapy or individual therapy, like kind of helps providers on the back end to provide the services without trying to figure out where else these services have been provided and if they've met those requirements for the year, like if those clients have met their requirements with another provider for that year.
So taking it, so what I'm understanding is taking it out of that category or removing that prior authorization from it would essentially enhance the availability for someone to continuously seek individual therapy or group therapy through an IOP program. Does that sound right?
Yes, I would say yes and no. So the availability, I think, is there. 9 times out of 10, if it's just you're just requesting individual therapy, Medicaid is going to approve it. They're usually not saying no, you can't have it. So it's just extra paperwork, I think, that's having to be done by providers on their end before the client can be seen for services. They do offer like so many free sessions a year without prior auth. But if, let's say, a client went to another place and they use those free sessions, now they come to you, you would have to put in that prior auth before they can get services from you. If that
Yeah,
makes sense.
yeah, no, it does for sure. And I've always been on the lookout for opportunities to help people access services in a more fluid and easy sense. But the insurance part, I think, has been a limiter. Karissa?
Thanks, Chair. Karissa for the record. So I agree that insurance practices can sometimes be a barrier, like an administrative barrier to people moving forward with things, or maybe even providers recommending certain things because it's going to be more burdensome. So at any point across any spectrum, from my perspective, we should be aligning Medicaid MCO practices and fee-for-service practices. They should do the same thing. There's not an argument that I can understand for why the fee-for-service providers and clientele should have to go through different processes and administrative burdens than those managed by a managed care organization. So I think 50 and 51 are valuable recommendations, and I think they should move forward.
That's 50 and 51, correct, Karissa?
Yes.
Thank you. I think that we are on the same page for 50 and 51 and that we should add them as moving forward. Can we address 52 and 41? I just don't know what 41 looks like, and I believe that 52 is already being done. Catherine?
So I'm not exactly sure what 41 would look like either, except for that I think that these funds could be braided with other existing funds that are addressing access to lethal means. And when we're talking about intentional suicide, intentional overdoses, addressing suicide. I just think these things go hand in hand. And I would like to see people have some conversations around this because I think that it's important.
Thank you, Catherine. I totally agree with that. It's a little foggy, but the intent or essence of it is meaningful. Let's highlight 41. If we could look at 52. Again, I believe this already exists, but if we had somebody to speak on 52 to clarify whether or not we should hide it or include it, that would be appreciated. And we also now have 53, 54, 55, and 56 available. If there's any questions on that. '53 looks good to me. Looks like something we should be moving forward. Not sure about 52 still. Any comments from the group? Oh, there we go. Catherine, is your hand still up or is that a new one? Thank you. Any?
Yes, I'm just, this is Quinny for the record. I'm just speaking on number 52. I do believe this is already in effect. Isn't this pertaining to like Center for Behavioral Health, the Allison Clinic, and places like that, Comprehensive Treatment Center? They already have these in those places, so I'm gathering that's already, like you said, in effect. 53, I am in agreement with 53.
Thank you.
Okay.
I think that we can hide number 52, and I want to look at number 54. I think that this one should be highlighted as well, specifically because it has to do with the rural and frontier communities. We have notes as high priority and feasible. I think that we should move that one forward as well. As we look at 55, 56, 57, 59, yeah, I think that uninsured and underinsured Nevadans should have access to opioid use disorder services and treatments. So I think that one should move forward as well. But as we look at 56, I'm kind of not too sure if this is something that's already been addressed and it has plans to be enacted towards. If not, then I think we need to bring it to light and sort of the essence will be meaningful as we move it forward as a recommendation. Pauline?
Thank you. I'm for 54, 55, definitely 59, because our adolescent beds have decreased by 50% in the state.
Absolutely.
And I'm wondering, like, when we say establish a Medicaid benefit, that, I mean, our recommendation just doesn't have Medicaid establish that, right? That seems a little over us.
Right. I think that, as I break it down part by part, the first part does seem a little off, but the use of a hub and spoke model seems good to me, especially with travel time and barrier transportation. And then we look at the next sentence, implementation of the model should also include establishing bundle payments. I'm not sure about that. But support building infrastructure for rural and frontier hubs is right up my absolute need and priority. That being said, if we stick to the hopes and essence of the recommendation, I think that it will do some good and have some eyes moving towards what that looks like to develop infrastructure in rural or underserved areas. So there's no opposition or questions about that one. I think we would do well to see that one highlighted. I was kind of confused on the 57 expand. I guess I'm not sure about this one. Inclusion of non-traditional community resources to serve as spokes. We kind of talked about this one. Oh, just had a issue on the technical end. It seems like we're having some severe technical difficulties. Are you guys seeing this as well? Okay. There we go. Looks like we're close to back on track. Quinny's hand stopped flashing a bunch, so that's giving me some hope. I'm going to turn my, oh, the host has stopped my video, but I'm here still, I promise. Can I get a confirmation from Joan or Dawn that we are back on track with the technical difficulties and we can continue looking at number 57 and 60?
This is Dawn. I think we're good to go.
Okay, thank you. A little bit thrown off from where we were, but if we could continue on 57, 60, 61, 62, 63, and 64. Any comments or clarifications on those? We kind of had one that was similar to 57 where we were considering the use of non-traditional community resources to serve as spokes as part of the hub and spoke model. Expanding the certified community behavioral health clinics and the integrated opioid treatment and recovery centers. I don't see how we can go wrong with that, but I'm just not too sure on what the intent or how this would look in practical application. Any comments to 57 or any of the others that we're currently going over? Yeah, and as I look at 60, I see the same type of thing is like, if we could ensure training opportunities and that there's enhanced reimbursement for the use of specific evidence-based models, we may be able to negate the lack of best practices. Nah, I don't know. Then kind of just seems like it's reinforcing the same thing that's happening right now on 60 at least. Any thoughts? I see no hands. There we go, Pauline.
And I think they're pretty similar too, so I'm just trying to keep reading it, trying to figure out, but to me they seem similar.
Yeah, if we look at the, sorry, if you have more, Pauline, please, Cornelius.
Thanks, Mr. Chair. The only difference I'm seeing, not the only one necessarily, but in 60, there's the emphasis on state-sponsored training opportunities marketed and available to providers in rural and frontier areas. That's, I think that's really important. You know, and Pauline, maybe you could speak to that more, but I know access to trainings is difficult for a lot of folks. And so anything we can do to emphasize that, I think, is a positive.
Yeah, yep. And you know, like I said, we kind of spoke on 57 as far as the inclusion of non-traditional community resources. I don't know if we want to take that one out or move it forward because we've kind of covered it. But I'm with you on 60. I think we should include that one. Pauline?
So I would support 60. And the 61 I don't support, that's incentivized, and I think that we had already discussed that. And then anything that supports care coordination, supportive of that. I think that if we support 60, 57 is I don't know. I support 60, not so.
Okay. Thank you for the clarification. We have two that we have hidden and two that we have added to the recommendations. How do we feel about 62? Oh, I thought it was. I thought Medicaid covers the, what am I missing? Covers the inpatient.
I think this is the, sorry, this is Pauline. I think this is the room and board portion, right? Like Medicaid doesn't cover our room and board portion for our kids either. Like we pay that amount. So I'm wondering if that's, we're asking for a waiver that would cover room and board.
This is like a
Not sure
policy one,
what that
maybe.
is.
Well, I think that having access to services would be in, priority. So I think that if not having the inpatient portion or the room and board portion covered would be a barrier, then we should include it as something to be considered. What are the committee's thoughts on 62? Comfortable with moving that forward? Cornelius?
Is Cornelius, yes, Mr. Chair.
Thank you.
In agreement. Yeah.
All right, let's look at 64 through 77. Any comments? Jessica?
Yes, I just wanted to let everyone know that I have another engagement that I have to go to, so I am going to jump off the meeting at this time.
Thank you, Jessica. Thank you for being here and thank you for participating. And we will send you the next meeting information when we have it.
Excellent. Thank you. Have a good day, everyone.
I think that 64 already exists. I think that it is happening at this moment, but if it's not, we can include it. I think that we see a lack in 65, so that one should be included. I'm not sure what 66 represents or is aiming to target, but I know that there are gaps and holes within the whole of withdrawal management services, so I would advocate for that one to be included. Any thoughts, comments? Oh my goodness, if we could increase short-term and long-term rehabilitation capacity through capital projects or funding of those existing services, that would be excellent. Dr. Camera?
Farzad here. Yeah, I guess from this perspective, I agree with these principles. I'm just not sure how this plays out with opioid funds. For example, like increased withdrawal management services. I don't know. I don't know what that means or what we're talking about. Are we talking about like evidence-based programs that provide withdrawal management services? So same thing, sort of, engage OB-GYNs and ECHO project. Yeah. So I'm just not quite sure.
As a whole, they are important, but specific verbiage or intent of these recommendations is kind of confusing, is what I'm saying also. But the essence of them is an absolute, right? Cornelius?
Thanks, Mr. Chair. I'm in agreement with what Dr. Kamyar said. But with 67 and 70, I think, when you talk about the essence of things, I think they're important to move forward. There's certainly a lot of what we're about, even though they're vague, I think is a sentiment and the essence of. They're important to move forward. Again, with the knowledge that they'll get sorted out and down the road.
Thank you.
Thank you.
Pauline?
Yeah, I think, I agree on the sentiment, but to me that's really broad with not a lot of specifics, and I think our whole goal is to increase direct services, which is what we've been identifying in our priorities. So I'm not set on moving those forward as they are. I am, I do like 73. And I do like 77, especially for our rural areas. Transportation is such a responsivity factor. And I like 78.
Yeah, that makes it really confusing, or at least hard to move forward from this point. Cornelius.
Thanks, Mr. Chair. Pauline's comment, her argument makes sense to me. And so I'll just sort of stay neutral on those recommendations and go where the committee goes. Thank you.
Oh, Cornelius, I needed you on that one. Yeah, and so that's where I'm at too. The whole of 66 through 77 at least are important, need to be addressed, should be looked at, and this committee should have, they fall under our concerns and what is a priority, but because they're lacking in meat and they're just bones, it makes it conflicted as far as do we move them or not. We're going to have this comprehensive list moving forward. I think that the mention of increasing short-term and long-term capacity is along with the rest of them is important. Cornelius?
Thanks, Mr. Chair. I am behind you on those. I think Pauline's argument is a good one.
Okay.
But if we're going with the essence of things, like I said, let's go with the essence of things. I mean, some of these need to be refined, but I'm with you in moving those forward. If any other member had more to offer in terms of moving forward with the essence of things, I'd be open to hearing that.
Thank you, Cornelius. I appreciate that. Dawn, let's go ahead and highlight 66 through 77, move down to 78, and we'll take a look from there. We talked about this one multiple times, 78. I think that it is important to take a look at the opportunities, but again, we've talked about this one. Quinny?
Yes, I'm in agreement with number 78. I think that is very important to, have this process in the faith-based organization, because just from life experience, it's like sweep under a rug. A lot of them don't talk about it. So if they have it there in, where it's in reach, where they'll be able to understand it and not look at it as something that they don't want to look at, will be good. So that's all.
Thank you. Let's highlight number 78 and Cornelius.
Thank you. In agreement with 78 also. I practice from a secular perspective, but for a lot of folks, the most trusted sort of provider sources are going to be within the faith community. And so just to help them with their trust and access, I think it's critical.
Great.
Thank you.
80 seems important, but not a priority in my opinion. 82 already kind of exists as far as I see it, and not a priority to enhance that specific connection. Obviously 83 is dear and near to me. I like the wording and concept behind 86. I'm not sure about 87. Any comments, Brittany?
I'm in support of 86.
Great. What about 87? Sorry, Brittany, we talked about this one a little bit earlier, so I thought that would be right up. what you know about. Karissa?
87, I think, is important. It's just, it's hard. I think it's important. I think it needs to go forward. It would probably just need to be wordsmithed in some way once it gets to them to be implementable, implemented. Those kind of things, like having stuff go to Medicaid first and then filtered down to DPBH is probably going to be logistically interesting, but it is something should happen in terms of reducing the administrative burden. Because I've had community-based organizations and even the counties themselves turn down funding from public health because it wasn't like enough to make a difference to them. So there has to be a way to do better at getting the grants out and leveraging where Medicaid or other insurance sources can pay. So I think it's an important recommendation.
Absolutely. Thank you, Karissa. Pauline?
I am in support of 88. I think that we have to do better with our Native American tribes. So I am in support with that. I'm not in support of funding an office or position that increase adoption support for SBIRT. We have priorities that include SBIRT, and if that goes through and they want funding, then I guess they'll have to do the SBIRT training and implement it. So that's how I look at that one. And not sure, 115 is, I mean, anything we can do in our schools is important. I'm not sure what mandatory prevention education that they're looking at.
Right. And that's kind of the way that I've been looking at the next 118 through 123. I'm not sure what that looks like. Catherine, do you want to speak on how you feel about these ones? Or does anybody? I think that the specificness of 115 kind of throws me off a little bit. Pauline?
I guess that some of these is like increase access to after school, summer rec, intramural programs, like that. Some of that's, to me, that's already implemented, like through our Boys and Girls Club. The schools do their sanctioned sports. I think that, I mean, some of this is either included in priorities we already identified or currently being offered. So, yeah. Not looking to move any of these forward.
Right, that's where I'm at. You know, as a whole, all the way up to 125. No, I want to keep 125. I'm going to keep 125, but I need a comment from the rest of the committee as far as 115 through 124, move forward or hide them. Karissa?
Okay, so this is Karissa for the record. I like 115. If you can't tell me it's happening well somewhere else, I think it, for me, falls into that like essence of our intentions kind of thing. Yeah. So I think it's important. I had done some work with the school folks in the past, so I think the MTSS recommendations are important. That kind of training in systems can really help schools to like implement better services and more holistic care for all children, including fostering their social and emotional development and their own resiliency. I don't know about the increasing after school summer like that seems very broad. So I would be in support of removing that if others are. Prevention specialists, I like it, but maybe it could be tied up in other CHW activities. I think 122 could be worth keeping because it's specific to parent education and resources for SUD prevention. So I think that gets to what we're doing. Parent education on ACEs may be very broad. Families First Prevention, I think child welfare really kind of falls into the DCFS category. I see the note here. The plan's written, but it needs funding. Isn't DCFS getting an entire grant for this? So I'd say maybe it doesn't need to be in our recommendations from this committee for how the opioid settlement fund should be used. And then I'm for 125. That's my spiel. Thank you.
Awesome. Well done, Laura.
Thank you, Chair. I am supporting 115. In particular, I know the school system does have an All-Stars program. However, I don't know how often that is updated. So my suggestion here is to work with experts in the field and bring all of our information current to what is happening in our state as a whole.
Thank you. Catherine?
And I would just agree with Karissa and Lauren and the statements that they made and the areas that they selected. I think a lot of these things are related, and those of us who working in prevention can see the connection between all of these things. We just want to make sure that that is something that's apparent to everyone that's looking comprehensively at prevention.
Okay. As we look at 127 through 148, how do we feel? For me, I feel like a lot of these have been covered. That being said, Pauline?
Yeah, I mean, we did talk about expanding adolescent treatment options in two of our other priorities, like increasing beds and then outpatient, intensive outpatient. I like the trained providers on evidence-based for family-focused SUD treatment interventions. I do like that one. Provide specialty care for adolescents in the child welfare and juvenile justice system. I don't know if it's specialty care or just provide care, like provide services. And then expand options for transitional age youth for treatment. I'm wondering if this came from DCFS or the state, like what for transitional age youth for treatment, if they're not involved in a system, like for us, we have our kids who are transitioning out, but if they're not involved in a system, they would either go into the juvenile or adult, depending on their age. So I don't really understand what the intention is behind that one.
Right.
And provide support for our CSEC kids. That's a huge priority for our CSEC commission, and I think that's very important. There is specialized treatment that is beneficial, that's evidence-based for our CSEC kids, so I do agree with that one. And I'll stop talking now so someone else can.
Thank you. Brittany?
I'm not sure if we covered this one in the housing, but I will also be interested in 138 and also 148 as well.
Yeah, 148 stood out to me as well. Karissa?
So I was reading, sorry, 141 and then feasible CACRN number 98. Keep this as programming. I like 141. If it's covered in 98, it doesn't need to move forward as its own thing. CARA plans of care and getting those implemented more effectively is very important to the maternal child health community.
Absolutely. 146 was covered in a previous one, so I think that we can hide 146. Incentivized treatment recruitment is challenging for me, but looks like it can be combined with 18. So hiding it might not be too. I don't think we'll miss anything. Cornelius. You're on mute, Cornelius.
I'm so sorry. That's been an issue today. Supporting 151, the street outreach teams to provide street medicine. I think in the munis it's especially important, but would support 151.
Thank you.
Thank you.
159 we spoke about and have covered a couple of different times. Low threshold prescribing. I'm not sure what that looks like. We talked about the 1115 SUD waiver. We can take 161 off. I'm not sure what 162 speaks to. Is there limited access for 164? Because that seems already existing. Karissa?
Thank you, Karissa, for the record. On 165, I would like that. Could we, since that, I don't know if that was one that comes from a state agency. I don't know if we can make a recommendation that it says establish like and or expand, because I believe some of our home visiting models do serve folks suffering from opioid use disorder. Thank you.
Thank you. 168, I think we covered is important to this committee as well. Pauline?
I mean, I do think 166 is important, but again, that's going to be with our workforce development.
Yeah.
Because we need that, and we need that too. We just don't have people who specialize in grief counseling.
Thank you. Brittany?
I was just going to say I also support 166 as well. I like that it's specific to people who are impacted by loss of fatal overdose.
Thank you. 150 looks like there's nothing wrong with that one. Also, it directly aligns with what this committee aims to do. Darcy?
Oh, I just wanted to say that I'm in support of 166 as well.
Thank you. Is the committee comfortable with removing 160, 162, and 164? Cornelius?
Thanks, Mr. Chair. Can anybody speak to 162? Karissa? I couldn't even decipher the language in 162 before I endorsed removing it.
Karissa?
This is Karissa for the record. Yeah, I think 162 is supposed to be IOTRC. So it's that hub and spoke. So I would read that as establish a hub and spoke model in Medicaid's policy with funding. That's what that is saying.
So we already have that, or do we need to include that?
Didn't we? It isn't. I think that's up in like somewhere in the other hub and spoke stuff. We're telling Medicaid they need to use it, expand it, implement it, all of that. So I think it's covered.
Agreed. We're at the last 5 minutes of this meeting. I just want to know if we need to move 160 forward, 164 forward, or not. Not. 102 is the last one that we need to consider, and I'd just like to make a statement that there is what we're aiming to provide for the state plan. I'm pretty sure does not include victim compensation. And, oh, I guess at the last meeting, I asked you guys to block out more time. So if I'm just gonna feel a little less pressured. And Pauline?
Yeah, I mean, I'm not comfortable with 102 and plus there's VOC money that's distributed nationally through the state to the local jurisdictions. And
Thank
it's
you.
pretty clear it does not meet the intention of the settlement, so I
Right.
say hide it.
Darcy?
Well, this is mine. And I believe that the initial settlement was for families, according to the AG, families, and for those that were victims of opioid abuse, opioid overdose, opioid prescriptions. And so I am in support of this. I don't know, it says it doesn't meet the intention of the settlement for the AG, but I don't know why it doesn't, coincide. We are affected by, funeral costs, going to pay for rehab costs, any of those things that are out of the pocket. So I don't know how that would look, but I really think that victim compensation should be highly regarded. And this is my one that I would say I want to put forward, but I have to hear from the committee and find out, how they feel about it.
Dr. Kendra?
Yeah, Farzad here. Right, I threw this one in and I wrote down, possible example to follow could be October 1, right? Because this not my area of expertise, but I thought along with what Darcy had just mentioned that there was this victim-ish thing that was part of it. So I don't know. I'm not gonna, I just threw it in there because I remember I think in public comments early on, there was stuff about what about the victims, et cetera, et cetera. So I think it was important to call it out, but I have no idea if it's within the purview of this committee, if it's within the purview of the settlements. I thought it was, but apparently not. But I guess investigation, et cetera, et cetera.
So my understanding is that the note for 102 is accurate. It does not meet the intention of the settlement. And specifically, the goal is abatement. We stick with abatement, the ending, reduction, or lessening of the harms, impacts of the opioid epidemic. But I'm open to hear more conversation on this. Darcy?
I was just going to add that this was one of the recommendations that I wrote down that was not added to our list. I thought this was mine that I had added, but Dr. Camriar had added it. So I want that to be noted in the record. I looked through everything. I couldn't find it, so I was very disappointed. I think the impact for those that are victims is part of this compensation that should be made for them. I think going forward, what am I trying to say? Just the outcomes from what happens when you have somebody with substance use disorder, when you have somebody who doesn't have insurance and you're paying for those things, when you have a child who you have to put through rehab several million times because insurance isn't covering it. When you have a child who dies and you have funeral expenses, there are so many things, and these originally had come from the opioid epidemic, which started back when prescribers were overprescribing, and we are collateral damage. There are many collateral damages from that, and I feel maybe this isn't the right spot, but I need to know where the right spot is, that we should be getting compensation. This is, obviously highly on my radar because I lost my child to heroin poisoning, and that started from Percocet, which started from the Sacklers and overprescribing. So I'm just putting that out there, and that's really, not just the Sacklers, but J&J and many different companies that were involved with this, that we are getting money from for those, you know, because those of our family members and, you know, friends and whatever are affected and die and are killed and are overdosed and poisoned. So I'm going to get off my soapbox and thank you.
Oh, thank you. Thank you for sharing with us, Darcy. And I think that where we can go from here is we can add it as a recommendation. I just wanted to be clear that I don't know what it's going to look like as it moves forward to the state plan, but I think that highlighting it doesn't hurt. And if that's this committee's feeling towards, you know, this recommendation, then we should move it forward. Dr. Camera.
Yeah, I'm looking back at one of the, let's see, what is this? It was, Dawn had sent this out, looks like 5/18/2022. DHHS Advisory Committee recommendations for the fund. And I'm scrolling to page, it's like gap identification. And then 16, 17, SB 390, use evidence to guide spending. Continuing, and there's all these recommendations, right? Programs to reduce incidence, severity of neonatal abstinence syndrome, et cetera, et cetera, et cetera. Then it goes to slide number, looks like 24. SB 390, use evidence to guide spending, continued. It says other victim compensation to the families who have suffered a loss, those still struggling, and the expenses incurred for treatment, funerals, therapists, medicine, et cetera, et cetera. So yeah, I would like clarification on where we're saying this is definitely not the intention of the settlement.
So with that one specifically, I'd just like to note that that was a recommendation from the ACRN, and I believe probably that one came specifically from Darcy, and that's how that got included in that slide deck. And again, if it is something that can be done and addressed, then I think that we should move it forward. With that, I have a note from the a statement by Attorney General Ford that he addressed this in the last surge meeting and said that victim compensation is not included in terms of the lawsuit. The AG's office sued for harms, damages incurred by the state. That being said, let's move it forward. It seems to be important, and we want to have this looked at and considered as the state makes its plan and we get this to the director's office. So we will include it. Now we have a complete list of agreed upon recommendations by this committee. And at this time, I would like to hear a motion to move the approved recommendations to the ACRN report that will be going to the director's office for consideration into the state plan. Cornelius.
Thank you, Mr. Chair. Motioning to move the approved recommendations forward.
I'll second Karissa for the record.
Thank you, Karissa. Jessica? Jessica, you're on mute.
Nope, I just want to let you guys know that I was done with my other engagement and was back on.
Great, thank you, Jessica. So we have the motion. We will now take a vote. All those in favor of moving the agreed upon recommendations that will go into our ACRN report to the director's office for consideration as they build the state plan, please say aye.
Aye. Aye.
All those opposed, can I get a no? And any abstentions? The motion has passed. And at this time, we will move forward to agenda item number 5, which is discussion and possible approval of the draft ACRN report. Now that we have our recommendations finalized, they will be added to the draft report. State staff has made the changes that they received as far as notes for the report that is going to the director's office. And at this time, I'm looking for a motion to approve the draft report for submission to the director's office. And that's with the understanding that our recommendations will be added, showing the recommendation, the gap, and the legislative intent, as well as the rating for those recommendations that have gone through the objective tool.
Brittany Collins, for the record, I motion to approve.
Thank you. Do I have a second?
This is Pauline. I'll second.
Thank you, Pauline. So we have a motion to approve the report, knowing that the recommendations will be added before the report is sent. We will now take a vote. All those in favor of moving the ACRN report to the director's office as a finalized report with the recommendations added, all in favor, can I get an aye?
Aye.
Aye. Aye.
Aye.
All those opposed, can I get a no? Do we have any abstentions? The motion to move the ACRN report as final with the inclusion of the recommendations to the director's office has passed. At this time, we will move to agenda item number 6, which is a discussion about the date for our next ACRN meeting. We had initially scheduled it for July 20th, but I would like to discuss moving that date to the 27th, July 27th, Wednesday, because of scheduling conflicts for many of the committee members. We will be getting a agenda with our meetings, our minutes from our last meeting, as well as this meeting, and we will plan on meeting on July 27th, Wednesday, 9 a.m. till we're done. Till 12. I don't think we're going to need 3 hours, but it's. I just want to leave that block open for scheduling. I guess. Can I get a comment or suggestion for the time that we will block out that meeting, and can I get some confirmations from the committee that Wednesday, July 27th will work, so that we can confirm we'll have a quorum?
Chairman Sanchez, this is Pauline. The 27th works for me. I don't know if that's what you're looking for, but
yeah, that's perfect. Thank you. Dawn and Joan, do we need it set for 3 hours or an hour or two, or what are we thinking on this one?
This is Dawn. We will just set it for the 3 hours because that's been typical. And then if we don't need to fill up that entire time, then you'll have a little bit of time left in your day.
Thanks, Dawn. So far I've got Pauline agreeing that that's an okay time for, I'll just accept that the rest of the group is looking like they'll be there and we'll have some type of quorum. Laura, what about you?
Oh, absolutely.
Thank you. Well, Nisha?
It works for me.
Thank you. All right, we will move from agenda item number 6 and agree that we are going to have our next meeting Wednesday, July 27th, 9 a.m. to 12 p.m. And we will move forward to public comment number 2. At this time, I would like to take public comment. Just keep in mind that with consideration to others who may wish to speak, provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. Do I have anybody available or interested in speaking as part of public comment? I have one hand up. I have Jeanette. Jeanette
Yes.
is in. Thank you.
Good afternoon, Mr. Chair. Jeanette Bells on behalf of the Nevada Psychiatric Association. This is more just a process question. So the when will the draft report with all of the recommendations be available for the public to see? You did a great job today. Kind of hard to follow with the numbers all over the place. And so just wondering when that might be available. Appreciate it. Thank you.
Thank you, Jeanette, for your question, and thank you for being here today to try to follow along with us. It was a lot, and I appreciate the committee's commitment and focus today. We got some good things done. The draft report is currently available on our ACRN webpage, and the only difference that you'll find in the finalized report will be the inclusion of the voted and approved recommendations. I think that is going to be submitted to the website as well. That's the inclusion of the voted and approved recommendations. I'm trying to get a date for you, but I imagine a week or so. But let me see what that looks like.
This is Dawn,
Hey, Dawn.
Chair, if I may. The
Please.
report is due to the director by June 30th. So we will
Okay.
have a completed and finalized copy up on the website by June 30th.
Great. Thank you for your response on. Jeanette, does that clarify for you?
That was absolutely perfect. Thank you so much.
Thank you, Jeanette. Do I have anybody else interested in public comment at this time? I see no other hands raised. No indication that anybody else would like to speak at this time. That being said, I will move forward to agenda item number 8, and I will adjourn this meeting. Thank you again, committee and public, for attending. Thank you, committee, for your commitment and hard work through this meeting and these last couple of meetings. Happy to see that we successfully came to a conclusion and got some recommendations together for the director's office and that will be considered for the state plan. Our meetings will slow down from here moving forward, but I do want us to continue meeting once a month until we can agree that we can meet once every other month. But for now, thank you and have a good rest of your day. I really appreciate you guys' work today. Thank you.
Thank you.
Thank you, Chair.
Thank you.
Bye, everyone.
Thank you.
Everyone. Bye-bye.
Thanks.